You guys ready to go?
Sure. Yep, absolutely.
All right. All right, hi guys. My name is John Seiberth. I work for the city of Perrysburg Fire. Been there for 20 years. Promoted to what now is called a captain 11 years ago, something like that. And when we were promoted, we had new monitors at the time, and we had this new technology, capnography, right? So what I found at the time is that not many people taught it, not many people knew it, and not many people used it. And we actually had an interest in using it, but when we started using it, it just kind of faded off into the distance, and it just kind of got left there. And in the meantime, I wasn't sure we should be using it because I'm kind of cheap. I don't like to pay extra money for supplies that I don't think we need. And but I did my due diligence, and I started doing some research on research papers and what's out there on the topic, and realized there's actually a lot to this. And the more that I looked into it, the more I realized that it's a vital sign. And it's probably the most valuable vital sign that I feel that we use. And now we actually use end-tidal CO2 monitoring for everything. Like pretty much if a patient gets oxygen by cannula, we use it. And we use that as a very valuable vital sign. So I'll try not to stand in front of that. I know we got a small crowd today, but what I do a lot of times when I do these presentations is I let people tap into a polling app, and I embed that into the presentation. So your thoughts, questions, remarks, whatever else can go up on the screen. As long as you guys don't get in trouble, I don't care. If you want to have fun with it, you go for it, okay? But it makes it a little bit more of a rich presentation and interactive. So if you guys want to, you can do one of two things. You can go to this web link, or you can download the app on your phone. And I'll give you a few minutes for doing that before we get started. Poll Everywhere. You can get it on Samsung, or you can get it on. I forgot. No, I don't have it. Okay. So while you guys are doing that, if you don't have a smartphone or something, you can actually text and answer sometimes too. But I'm guessing most people have smartphones. So I understand you guys, your new monitors are in service?
Yes.
Right. Are you liking them? Mm-hmm. And then you're back to life packs. I'd like to thank Jillian for setting this up as well. I mentioned to Jillian that Medtronic, who I'm technically going through today, Medtronic is the technology that's embedded in the physio monitors. Or is it still physio or is it Stryker? Stryker. The Stryker monitors, and then the equipment that you guys use is also Medtronic. So Medtronic has an education program where they send a few of us around in the country to do these types of talks. So, okay, if you guys think you're ready, I'm going to flip forward a couple screens, and we'll start up a first poll, and then you'll see what happens. Okay, this should just get you a warm up.
370?
Yeah, yep, I'll go back, and then if I go back right now, then everybody else will be able to see if I can go back. Yeah, there you go again. So everybody else should be able to see the poll right now. All right.
No, I'm responding as ISAC.
Yeah, it looked like I picked up on a different poll, so I always test this beforehand, but I was running a little short on time. I tested at home last night. I guess it's depending if I have a web connection right now too, actually, which is what I need the web connection for. All right, it says I'm on.
Moderately, actually.
Yeah, I usually like to look at your protocol too. I didn't get to that point. So what does your protocol say while we're at that? I heard one.
If you have a difficulty breathing or anything like of that nature, they should be getting it put on.
Diff breather, so non-invasively.
Yeah, we have the cannula and then the same way.
Okay.
VVM with Stanley's going to say today we switch from one run, use both sets.
I'm pretty good about, I would say, it always gets used, or I would say it should always get used anytime we have an arrest.
Okay.
Other than that, it's hit or miss.
Okay. So do you guys think you're? Do you guys think you're 100% on arrest using it for tube confirmation?
Pretty close.
Okay.
Pretty close on arrest. No, the diff breathers we're not 100% there.
No, it doesn't get, I don't think it gets used much. As far
Okay.
as the cannulas itself.
That's where we were at when I first started. When we first started this in Perrysburg, people were like, "We want to use this," and we embedded this into a refresher class, the training. And so a guy came in, did a humdrum training, but it was more guided towards intubated. And a lot of the guys were like, "Well, we want to do the cannulas," and I was actually the naysayer, and I was like, "Nah, I don't want to do this. I don't think there's much benefit to it." And hopefully today that'll change your mind because I changed my own mind. So perhaps I'm going to have to. I'm not getting my connection on, so we're going to have to roll with it and see what comes on, which is a disappointment. But I tell you, just got to roll with it.
Ain't that right, fellas?
Oh, for crying out loud. All right, so there's a fancy title slide. Let's get this moving on here. By the way, try to take breaks every 20 minutes or so. So, if you need a break, just let me know. This is the Medtronic slide. Everything else is mine. Medtronic basically says that what I teach you, I'm responsible for. And when I teach you things, I'm supposed to teach you things that are based on FDA-cleared uses and blah, 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 blah. And then if there's anything that I tell you that's different than that, I'm supposed to tell you. So, okay? All right, see if that pops up. Still not? Let's do that. I'm a little out of sorts, guys, sorry. So is it only an ALS skill? No. What does the state say? Scope of practice. Basic can do it. Is there any discrepancy between what a basic in Ohio can do and an advanced EMT and a paramedic can do? Yeah, it's not. In other states, I went to Indiana, and it was amazing that EMTs can barely use this, and it does not discriminate between that. Indiana is actually in the process of changing it, but it was very interesting teaching over there and discussing that. So no, there's nothing that says that an EMT cannot use this or should not use this or shouldn't know it. Okay, so EMTs are just as responsible. And by the way, EMTs, who's usually controlling the airway? They are. So you got to know it. Like, this is very important, because if we don't ventilate patients properly, or if we can't confirm that that tube is still in place, we're going to kill people, right? So very important. EMT should not necessarily dismiss this as only an ALS class. Okay. So there's your pieces of equipment. Upper left, we should recognize that, right? That's for intubated. Now, what I say is we should always use this for even bagging patients, okay? Because when we're exchanging gases, it tells us that we're getting our ventilations in the right spot. How many patients have we had that puked over the years that we're forcing ventilations down when possibly we didn't have the airway open properly? I'll give you some illustrations of that today with just simple bagging. Upper right, that's your cannula for the adult, bigger scoop, okay? And the way these work is you have carbon dioxide siphoning through the cannula itself and also in the scoop. So when it goes through the cannula, you have a nose breather. That's where it's sensing. The scoop is for mouth breathers. So either way, whether a mouth breather or nose breather, you should get that carbon dioxide. So does anybody know where the oxygen comes out of? It actually comes out like right here. There's a bunch of little tiny holes. and it creates an ambient oxygen. So if you give 6 liters per oxygen, you're going to get 5 liters of oxygen, just as a little note, okay? If you turn it up higher than 6 liters, it's actually going to distort your reading on your end tidal, okay? So it's intended for up to 6 liters per minute. Lower left, that's for 4.5 and below tubes, if you ever tube a neonate, okay? There's a little spring in there, and it controls the dead space. Because if you think about dead space, it can really booger up your sensing of that carbon dioxide. And then lower right is for peds, all right? I think you guys saw this one, and for whatever reason, it's not working. So where are we at? We've kind of said we use it moderately. Okay. All right, let's watch a little video real quick. Jumping out of plane, yeah. Yeah. I could do this. Yep. So I like using this video. It's really cute to watch. It's, you know, probably like a 12-year-old girl, maybe at best, and working past those fears and trying to learn something new. It's always challenging, and you have to be fully invested and ready to go. And that's what I like about capnography. Not many people know it until you get that buy-in, and no matter what it is, jumping out of a plane, there's always that fear of how is this going to work? Is it going to work out? Whatever else. And that's what I like about end titles. Not many people know it, and I really like teaching it. And I think it is most valuable, most valuable resource available. So as far as vital signs go, sorry, I'm getting distracted watching these audio visuals. All right, so advances in care and equipment. Are we actually using as much as we should or can? I think we've established already that we're probably not, right? Are we providing the best care? Are we doing enough? So hopefully today, after today, the information I'm going to give you is going to help you recognize that you can take your patient care to like a whole nother level and really have that satisfaction of knowing that what you're seeing in your patient is actually the right thing and that what you're doing is the right thing for the patient. Okay? And I'll draw some clear illustrations of different types of patients. I go through a ton of cases. All right? So we don't rise to the level of our expectations. We always like to think that we do, right? But if we don't have the adequate training, the proper training to get us equipped, then we're not going to succeed as much as we want. Okay, we established this already too while we're getting going, right? We talked about diff breathers, arrest. You guys ever like knock down a tube anybody prior to arrest? Do you guys have it in your protocol? What's that?
Not very often, but
Okay. Do you have the capability in your protocol to sedate, intubate?
we have a RSI protocol that is
Lackluster?
Maybe needs to be updated.
Yeah, we're in the same case.
We don't have great drugs, but we have the ability to do it.
What do you have?
Yeah.
Okay, that's what we had before, and we Versed and fentanyl combination is really bad. It causes hypotension. We've actually moved to ketamine, and that's actually so far been really good. So That's been nice, and it's safe.
It doesn't get used much, and when it does, it's ineffective.
Which one? Versed fentanyl?
Yeah, it just,
Yeah. Yeah. We'd like to move to complete RSI. We're not quite there yet. So when you do intubate them, it's important that no matter what, whether arrest or not, it's important to use that. Ventilation, perfusion, metabolism. Those are the three things that capnography is tied to, okay? Could be one of those things, could be two of those things, could be three of those things. Most of us think about the ventilation thing, no problem. But how many of you actually knew that perfusion metabolism can be somewhat related to end-tidal use? Okay. We can use that based on understanding the kind of the pathology or pathophysiology behind it. We can use that to assess different types of patients that are having situations where they're really sick, dehydrated, hypoperfusion, trauma, shocky type patients. Okay. We can also use that for ketoacidosis type patients. All these different things that totally opens up the entire road as far as patient care goes. This is the most important slide. Everything I go over today is related to this slide. So you either have a ventilation issue, you either have a perfusion issue, or you have a metabolism issue, or you have two, or you have all three. Okay? So keep that in mind when we're assessing our patients here. All right, so some very basic things. Here's a strip off a striker, monitor. You got lead 2, you got a heart beating, right? The next one's your SpO2 pleth. Looks like you got a good pleth, got a good beat. And then the bottom one is the end of a end-tidal waveform in a flat line. Is flat line good in an EKG? No. And of course it's bad. That means that something's wrong, right? Tubes disconnected, tubes out, not in the right place. It's an esophagus. Something's not right, right? So EMTs, this is something you got to keep your eyes glued to. Sometimes we turn off the alarms on our monitors, so you are the alarm. All right, if we see something like that happen, we need to react immediately. There's something called a VQ ratio. It's probably the most confusing thing that I've ever had to try to learn when I taught myself. Okay, so you have ventilation perfusion ratio. For every amount of air that you're breathing in, there's a certain amount of blood circulating around. Okay, so that's all this really is. But in a normal physiological state like we are now, we have roughly 4 liters of air that we breathe in a minute. We have roughly 5 liters of blood circulating. Okay. If something gets thrown off, then we're going to throw off our carbon dioxide levels. Okay? So if I breathe really fast, you got a typical hyperventilating patient. I'm breathing faster, so I'm going to breathe off more carbon dioxide. Make sense? If I breathe really slow, I'm an opiate addict, and I stop breathing, or I'm breathing really, really slow. Then I'm retaining carbon dioxide. Therefore, I throw that ratio off, and I breathe off. And I have a higher level of carbon dioxide because we're not ventilating as well, right? And then we can correct that by ventilating them, blowing it off more. So now, the perfusion aspect, that's where it gets a little more confusing. If I have a normal amount of blood flowing, and then all of a sudden it drops from whatever issue there is, I'm throwing off my ratio. And in a case of blood dropping, am I circulating as much blood back to the lungs? No. So even in an arrest situation, we're not circulating as much blood back. So any of those different types of situations, we have a lowered amount of return blood flow. So we're going to have less carbon dioxide coming out of our tube or whatever else it is, or if the patient's even breathing on their own. Okay. Doesn't mean that there's less in the body system. It just means that it's not getting out where it needs to go. Make sense so far? And we're just establishing a few things. We'll keep on working on this as we go on. So then, that's just the teeter-totter, right? And then the other thing you think about is like the really sick patients. You guys ever have like super sick patients that have pneumonia, something like that, or you suspect they have pneumonia? They got a really low pulse ox, and no matter what you do, you can't get the oxygen levels up. SpO2 levels just won't climb. Okay, that is probably the worst case scenario that we could have as far as trying to oxygenate a patient. And there's a few different things going on in the lungs that we can talk about real quick. That one's called a shunt. Okay, so if we have a shunt is a roadblock. So if we picture all these alveoli in the lungs, and we got gas transfer, we got blood coming and exchanging with the gas coming in from the lungs, and everything's going good right now for us. If we have a shunt, we actually have a roadblock. So we had some. Did you guys have flooding down here with the rain? There was some flooding. Okay. Can you get past the road? Usually you can't get past the road. If you can, you got to go real slow. You got to be real careful. That's what a shunt is. Okay, so a physiologic shunt is actually where the alveoli have so much crap in between that and the capillaries, it can't get past. So if you ever have a patient that isn't breathing very well and they can't get their oxygen levels up, they probably have a physiological shunt. And then in that case, we're not going to have good gas transfer either. Carbon dioxide can't get past either. So oxygen can't go this way, carbon dioxide can't go that way. Okay. There's another one that's not quite as bad. Maybe you got a patient that has pulmonary fibrosis or something, or maybe their oxygen sats are low, but they improve with oxygenation. Then you may have something called a diffusion issue. If you think about diffusion, it's passing through, right? So when we got gas passing through the alveoli into the bloodstream, normally it passes through good. We got a thin piece of paper, and oxygen and carbon dioxide pass through just fine. However, with the diffusion state, you might have a little bit of thicker wall in your alveoli, and then the gas can't pass through as well, okay, as far as oxygenation. The nice thing is, this will make sense a little bit later, but the nice thing is with diffusion, carbon dioxide passes through much more readily, so we may have a really good level. Okay, it'll make sense later, hopefully, at least a little bit more sense. But I just want to establish a few of those things: VQ ratio, diffusion, and shunt. Okay. All right, so let's talk about waveform comprehension. Does everybody know what a waveform is, first of all? Right, when we talk about end-tidal waveform, what does a normal end-tidal waveform look like? Plateau, square, box-like shape. So something like this, right? Would you agree? Okay. And why do they call it end-tidal? End-tidal CO2. End-tidal CO2 is that right there. That's your highest level. So this plateau kind of goes up and ends at that end is the highest number. And the reason it is because if we think about it, I like to look at it from this direction. This is your inspiratory phase. Okay, so that's when you breathe in. Everybody breathe in. Hold your breath. Breathe out. Full exhalation. Okay? So when you first start breathing out, if you think about it in this area here, that's when you're just starting to exhale. If you think about it, you're measuring here, right? And so the gases from up top are the first gases to come out. Do we have lots of blood up here? Do we have lots of gas exchange up here? No. Do we have lots of blood down here? Well, down here, right? And then in between, or the lower third, is usually where you have the best gas exchange, period, like with anybody, right? So when you first start breathing out, you don't have carbon dioxide rich, but as you start getting deeper and deeper from the lungs, you get carbon dioxide rich. And so that's why you have that end tidal, and that's why you have that plateaued like you should, okay? So let's step back a couple here. What about that diff breather? Like in what cases would you use that end tidal for your diff breather? Or when would you throw that cannula on? What type of diff breather are you thinking about when you're? Okay, so what are you looking for with your COPD? As far as waveform goes.
It's going to take more of a
Slope, I was gonna say.
Okay. Okay, at the beginning?
Yeah.
All right, good. So yeah, you got a slope. So if someone has trouble breathing, in the very early stages, you might actually just get a little bit of rounding in the front. All right. But as they get worse and worse, and it gets more pronounced, then you're going to have what they usually call a textbook shark fin. Okay. You guys seen that before? Okay. So that's like the true blue diagnostic type of thing. You can use a waveform for end tidal. Okay. When you get that diff breather, the COPD or the asthmatic or whatever else, this is a great tool to verify that that's actually what you think it is. If you don't see that, then you have to kind of do a double take and think, wait a minute, is there something else going on? Okay. So what's a normal level for end tidal CO2? What should we expect to see with the patient?
30, 40, or 35, 45.
Yeah. Yeah, they say 35 to 45. Generally, from what I've always seen, is around 35 to 40. If they get up to 45, usually they have a fever or something, right? Because fever is metabolism, and it produces more carbon dioxide. However, if there's something else going on, it may not just be that. So 35 to 45 is where we want to be generally for patients even that we're ventilating or what have you, or we're managing. That can change based on different patient situations. The important thing that I learned early on is when I was first taught this is I was told to look for the shark fin. Well, the shark fin's not always present in that COPD or asthmatic. So really what you want to be looking for is this front angle called the alpha angle. That angle right there. If that's not almost a 90-degree angle, it's more like a 120-degree angle, but if that's not almost a 90-degree angle and it's starting to curve in that front, then you should be thinking that maybe up top it's maybe a mild asthma. So you got a mild asthmatic, maybe you have some upper wheezing. As they get more and more pronounced, then you're going to have more and more of a shark fin because it's affecting deeper and deeper into the lungs. Make sense? All right. So when we use our end title, we want to do a couple things. We just evaluate the waveform, right? Evaluate the waveform always and continue evaluating it. Just like you're reassessing your patient, you do the same with this. Things can change. Evaluate the numbers. 35 to 45. If it's low, what's going on? If it's high, what's going on? If it's normal or if it's changed, what's going on? And then we have to think about that VQ mismatch that we just talked about. Okay? That'll come with time. And then also diffusion or shunt. Is that affecting our readings? Is that affecting our numbers? Sometimes it affects our waveforms, especially in diffusion or shunt. And then we need to evaluate our trends. Okay? Just like we do with EKGs, everything else that we do. We're just incorporating this into our assessment that we're already doing. All right, since this may not be working, usually I say, okay, here's our waveform interpretation. It pops up on your screen. I don't know if it will. And then this is the first waveform we're going to do. So let's look at that top strip. Is it popping up on your phone? No? Okay, so let's look at the top strip. We'll see after a break here in a few minutes if we can get that going. So do you see normal waveforms on the top strip? No. And notice that the line across the middle, the red line, is 35.5 on the right side. Okay. So is the number high or low? Low. What's wrong about the waveform? It's fast. So that means they probably have a high respiratory rate. Do we have a nice clean box-like shape? Okay. What do you see with those waveforms? Are they all the same? Are they consistent? Are they different? Yeah. Yeah. Right. So I'm picturing, you notice how they're staggering, like, so I'm picturing they're breathing fast, and taking different lengths of breaths. So it's irregular breathing. What about, like, some people say that's a bronchospasm waveform. Would you guys agree or disagree? See, it's not always clear cut, right? So here's my suggestion: is if you're looking for a bronchospasm waveform in that COPD or that asthmatic, typically when you have a bronchospasm waveform or even that beginning of a bronchospasm, they're going to be very consistent. Okay, very solid and consistent. So here we don't see that here. So here what I'm picturing and what this patient was is actually a hyperventilating patient. Okay, so use this in the context of the patient that's presenting in front of you, right? Always assess your patient and apply this based on that patient context. So this patient breathing irregularly, we're not worried about anything else, and we talk her down and we sign her off 20 minutes later. Okay, and we use this as a tool to talk her down actually. She actually was able to control her own breathing, and then there she is after she signed off. Okay, make sense? All right. How about this one, top one? Actually any of them, but the top one is probably most difficult.
First breathing, they're really struggling to get air out, so they're pursing their lips.
Okay, and why do you say they are having trouble getting air out? What do you see?
It's very prolonged
It's not drop at all.
expiratory.
Yeah, a little bit, not a 90 at the end or at the front. I mean, it doesn't drop straight off and it doesn't start straight up.
Mm-hmm. So do we see the box-like shape?
No.
No. If we were expecting a box-like shape, we'd want that, right? So we obviously have some type of curving in the front. And then these strips are about 10-second strips. So you can picture the respiratory rate as a little bit drawn out. That middle line, is it below the middle line still? So we're a little bit lower than 35. So in this case, this top patient was an asthmatic, but also was allergic to shellfish or peanuts or something like that, and she had Chinese food that had one or the other in. So we had someone, we have just about everybody back.
As many as you're gonna get until they get back.
Okay. All right, cool. All right. So I try to take like 5-minute breaks or so, try to be real quick to keep us moving, and it helps with blood flow too, man, moving around. So we talked about this waveform, right? So the top two is actually the same patient, and normally when we have a bronchospasm waveform, we expect carbon dioxide retention, right? So if we think about that patient that's struggling to breathe, and if we get a waveform that's kind of rounding in the front, that's delaying exhalation. So I always think of it as delayed exhalation. Someone's trapping air, they can't get that air out, so therefore they're going to be building up their carbon dioxide levels, and when they finally do get to that end tidal level, there's so much carbon dioxide built up in the bloodstream that we're going to have an increasing end tidal as the patient gets worse and worse, and as the bronchospasm gets worse and worse. Okay, so in this case, it's kind of low. Well, I mentioned this patient had an allergic reaction. So what happens in an anaphylactic reaction? What happens to the body?
Trying to kind of shut itself down for circulation.
Right.
Shuts down. Trying to keep, it's kind of shut, keep everything safe in here.
Third spacing,
Yeah.
right? You start getting third spacing of fluids, so therefore the circulation is not very good. Anaphylactic reaction, we expect to see typically a high pulse rate, low blood pressure. Those are all the different things. We look for shock-like symptoms, right? So this patient has, even though she has the bronchospasm involved, she also has a little bit of a lower end tidal than expected because she has two things going on here. She's got a ventilation issue, right? She's trying to breathe fast, so that actually might drop a little bit. But she's got more bronchoconstriction, right, due to the allergic reaction and or just her being asthmatic and freaking out. And then she's got a decrease in perfusion. So therefore, yes, she has a bronchospasm, but wait a minute, there's probably a confirmation here that, yeah, she did have an allergic reaction also. Okay, she's just not panicking because we seem to see something else going on. She's not having a panic attack. And so we treated that with epi, we treated it with bronchodilators and fluid and everything else that we do. Okay, simple illustration. And then the bottom one was another asthmatic. You can see that you don't always see the telltale waveform that you would expect to see for shark fin. Now remember too, when you do printouts, we obviously don't breathe as fast as our heart beats. So when you do a printout, you're going to have to do a long printout to look at your waveforms. And when you do 12 leads, do you just look at the screen on the 12 lead and go, yep, that's a STEMI, right? So we should always be doing that too with this, doing printouts and looking at our waveforms. Remember on the screen that it's condensed in time. So when you see it condensed in time, it might actually look more pronounced than what you see in your printout. So just keep that in mind, okay? All right, top two here. Should be no argument here. What do you see? Yeah, for sure shark fin. And if you look at it towards the end, this person's actually probably not getting close to a plateau. Like they're almost not plateauing in the end to where they're not getting their full exhalation out. All right. So notice how they're all equal though. They almost look all the same. So you shouldn't have to hunt and peck for shark fins. They should almost always be the same. Bottom one, it's not always very easy, but do you kind of see it? It's there. It's relatively consistent. But in a patient like that, I might consider maybe there's something else going on as well based on the level of distress. So they're breathing pretty darn fast to be trapping air. So I would think, okay, maybe there is a little bit of wheezing involved, but maybe there's something else going on. Again, we have to use it in the context of the patient. And, you know, interpreting this stuff is, you know, part skill and part like intuition to a certain extent once you know your patients really well. Okay. It's taken my level of care to a whole nother level. And I feel that way for the entire division now too. We're obviously in different spots, each person is, but I really think that it's made a huge improvement for us. All right, so what about this one here? What do you see changing? I wrote it on there so you can obviously see it, but so breathing slowed down, right? But has it gotten any better, do you think? So the respiratory rate's definitely slowed down. If you just look at this,
They're having an inspiratory issue of some sort, something with the regular.
okay. Do you see a normal waveform? Definitely not normal waveform. Okay, what's missing? Yeah, missing that plateau. Okay, so I would classify this as a shark fin. Patient's having a lot of trouble breathing. This guy was an asthmatic. Notice how the end tidal is relatively high, but not terribly high initially. But look at that shark fin. That's not good. If we don't correct that pretty aggressively, then things are going to get worse. This was many years ago where we were just introducing CPAP and we hadn't had it yet for asthmatics, so it was strictly for CHF. So we're a little bit limited on what we could do. But he got to the point towards the end there where his end tidal got up into the 70s. I don't have a good picture of that. But it got so high that he's just ripped off his mask and said, I can't breathe. And this is nebulizer mask. And we didn't have the ability to give nebulizer through CPAP at that time. We just had 10 centimeters of water. And we threw that on him, and he was happy as could be. We didn't correct the problem. We probably should have gave him a mag drip, and maybe actually probably hit him with epi. We probably should have did that, but we didn't. I'm assuming you guys have that in your protocol. Some people have mag, some people don't, but most of them have epi available to you for asthmatics. So we need to correct that problem. We did okay, but we could have did better. All right, so tube conformation. I'm sorry, this is a different patient. So this patient, short and stout, sitting on the steps in her tri-level house, difficulty breathing, sudden onset. So she's sitting there, and immediately we're thinking CHF, okay, just based on the presentation, based on what we're hearing audibly. All right, so what I always recommend that what people do is we want to incorporate this waveform as soon as possible, the end tidal as soon as possible. So we put on a cannula to start with. We put on a cannula right off the bat before we put CPAP or anything on. Why would we do that?
Medic 1, transport 1 to Tiffin Fire.
Baseline then, see if you actually did fix anything or you're making it worse.
Yep. And let's face it, sometimes we put CPAP on and is it working, is it not working, right? We can make it worse. So if we get that initial baseline, it works great. Then you know what you're starting out with. So this is, okay, get the CPAP out, another guy get the cannula on, another guy's getting the monitor on. You know, we're moving. First waveform there doesn't count because that's right in the middle of her breath. But what do you see with the next 2 or 3 waveforms? Does it look like a normal waveform? Mind you, for the most part, right? And so textbook is different than real life a lot of times. So we have to think about how this patient is presenting. So a little bit of artifact, right? She's breathing heavy. There's probably a little bit of little guppy breathing, and you know. But for the most part, I shouldn't say guppy breathing as far as like the fish out of water dying, but you know what I mean. You have changes in your respiratory pattern. So I'd say normal waveform. Even that third one, I know that that's probably just an aberration with her breathing pattern. Okay, so now we feel good. We got a plateau. Do I think that this is a COPD or an asthmatic or something like that? I would say no. Notice too, her end tidal is actually kind of on the higher end. She's like probably about 40 or so, but she's breathing really fast. I know you can't see it here, but each one of those blocks I think is a second. So she's breathing, the big blocks is a second, so she's breathing pretty fast. So why is her end tidal so high compared to how fast she's breathing? If I had a patient that was hyperventilating, I would expect a really low end tidal. Okay, so there's something going on there physiologically. Somehow. And so let's think about CHF for a second. What's going on in a true CHF patient, left-sided heart failure? What's happening to the blood flow, let's say? Lots of fluid. And where's the fluid not going to? Yeah, it's not going forward, right? Heart's not pumping right, can't pump forward, so it's got to go backwards. Everything goes path of least resistance. You know, water goes path of least resistance, air does, smoke does, right? So if we think about in that context, she's got fluid backing up, lungs aren't pumping forward, or heart's not pumping forward, lungs fill up with fluid. Carbon dioxide can actually go through that fluid very readily. It's not going to be interfered with. So we're having a buildup of carbon dioxide in the system in front of the left ventricle. So it's building up, and so her body's trying to compensate. 1, she's trying to stay alive, and 2, she's breathing really fast. So her end tidal level might be kind of normal, it might be kind of high, but we got to think about that's really building up in her system, and that's toxic to people. Okay, that's just as bad, if not worse, than having a low SpO2. All right, so then we put the mask on. Now, what do you see here with the mask on?
Levels came down.
Yeah, levels came down almost immediately. The waveform isn't exactly as clean. And if you put that cannula on without getting that baseline interpretation, some people might be mistaken into thinking that's a bronchospasm, because there are some of the waveforms don't look very clean, okay? But then she adjusts to the CPAP pressures and everything else, and now we're looking really good. Yep. Her respiratory rate's still very high. She's not out of the woods. We're hitting her hard with our nitro, and we use captopril, but even hitting her hard with nitro is going to help out a lot, because we want to, of course, help the blood flow go forward, right? So, great. Sound good? Any questions on that one? All right, so here's another one. This is a really cool case. What do you see on this one? High, fast. This is a tricky one, because what's the biggest thing that we're missing right now? Plateau. Good. Yeah. We're missing a plateau. And where is it? Why is it not there? We might get tricked into thinking that this is a bronchospasm waveform, but look at that upstroke. Is that a pretty good upstroke in the very beginning? So your expiratory upstroke is actually pretty straight up, which is pretty good. And then what we are missing is that right there. Okay? So I've seen this in several patients, and if you, sometimes these patients don't look that bad, but in this case she obviously had a high respiratory rate, and the paramedic was a resistant paramedic to incorporating this into assessment. This lady was standing, bending over, holding her ankles, saying that helped her breathe better. And he decided that she was a COPD asthmatic because she had COPD, and so he gave her breathing treatment, and then her waveform didn't really change at all. Nothing really got better, and she went to the hospital, and okay, but that was it. He didn't fix anything. He didn't make anything better, all right? And he thought he heard wheezes in the lungs. It's possible he did, but I can tell you that she's not showing it here. So what's going on? I think, one, either she possibly had cardiac wheezes and was a CHF patient. I can definitely tell you that the patient did not have end exhalation. So I've had other cases that are not as clean as this, where you put that patient on a little bit of CPAP, and it opens up those alveoli, and then boom, your plateau comes right out. Okay, now we know we're fixing something, we're on the right path. All right, so a few different things to think about with this type of presentation. Atelectasis, you guys know what atelectasis is? Sometimes you'll have fluid around the alveoli, the alveolar sac, and in the alveolar sac you have something called surfactant. Surfactant is what keeps the alveoli open, and if the alveoli collapse, then you're not going to get good gas exchange, and therefore you're not going to get good end exhalation. Okay, so a little bit of CPAP will actually help open up those alveoli and keep it splinted open and promote that good gas exchange, which is why then we get the good waveform. Okay, make sense? All right. I want to show you one other thing. Something we haven't talked about yet is, look at that baseline. You see that baseline there? And you guys know what I'm talking about with a baseline? Right here. Yeah, it should be down here. So that also confirms what I was just saying. If she's not getting to end exhalation and she's not getting all of her carbon dioxide out, then where's the carbon dioxide going? Yeah, it's recirculating. Yep, it's recirculating. Okay, so that's another sign that she's not getting full end exhalation. You also see this on some patients that you're ventilating. If you're over-ventilating them and you're trapping air, that can happen, okay? You can also see a rising baseline sometimes with that asthmatic that's trapping air. Okay? Favorite beer? Tough choices. Yeah. No. What do you like? I'd take PBR over anything. Yeah.
Absolutely.
I like IPAs. Huh? Busch Light. Cheap beer.
Free, cold, open.
I never understood the I can taste my beer commercials, because I can always taste my beer.
I was drinking Schlitz for a while. Kind of messed me up a little bit though. All right, so ventilation. It's hard to teach just ventilation, but I try to isolate these a little bit. because usually when you got one thing going on, you got 2 or 3 things going on. Like I mentioned, ventilation, perfusion, metabolism. So typically when we think of hypoventilation, we're talking about that drug addict. They're not breathing very fast, and we're going to expect what type of end tidal CO2 level in a patient that's hypoventilating. You got a drug addict, you grab the mask, you start to bag them, you put an end tidal on because that's what you're supposed to do after this presentation, right? Or even sometimes I'll throw the cannula on that patient because I know they're going to start breathing again. So I already have a cannula on, I can monitor them when they start breathing on their own. Or maybe I don't need to bag them at all. So I'll throw that cannula on, bag them, and I start ventilating them, or they're breathing a little bit on their own, and their end tidal is 70, 80, 90, right? Yep. Backlog. You got a log jab of carbon dioxide just before the lungs, and it can't get out because he or she's not breathing fast enough, okay? Well, in this case, this was a nursing home patient, and the nursing home patient, we get called, and of course, it's not my patient. I'm usually not on this floor. You guys ever hear that when you get called to places like that, right? Yeah. Yeah, it's a universal language. Yeah. So it's just never. So this patient, the nurse is busy, of course, handing out medication. This lady is laying on her bed, and she doesn't look that bad, but she's not breathing very well. And then we hook up the end tidal, and this is what we see. So do we have a waveform, a normal waveform? Do we have much of a waveform at all? No. Not at all. Remember, when you're evaluating your patients, in order to get a carbon dioxide level, you need 2 things. You need tidal volume, and you need a respiratory rate. Is this lady breathing?
Yeah.
She's breathing. We can confirm that. Do you think she has a good tidal volume? No. So our reading is not necessarily accurate, but that doesn't necessarily mean that this thing isn't working. It actually tells me that she has something called hypopneic hypoventilation, okay? So our typical hypoventilating patient, we expect a good tidal volume but a low respiratory rate. Here she has a good respiratory rate but a poor tidal volume. So even though my tracing isn't that great, it's actually telling me, hey, we need to do something. So it turned out she was on some type of opioid pill. Guessing either she got into something or they gave her too much. We gave her a tiny touch of Narcan, started breathing, and woke up actually too. Started breathing better and probably didn't need to take her anywhere. But so keep an eye out for that. All right, you can use it for ventilation. You guys ever have any traumas out here? Decent traumas that you're intubating, anything like that? Yeah. Yeah, I bet the county probably gets a decent amount. Do you guys run out there at all, or?
Yeah, we get out in the county quite a bit, actually.
Yeah. I worked in Findlay area. We had so many traumas out there in that area. But yeah, so you can use this for a few different things, right? You get a closed hit injury. You can obviously, if you intubate somebody, you can manage their ventilations. How would you guys normally manage ventilations with that type of patient, a head injury patient? Like, what are you thinking about? Because we can use this to manage our ventilations, right? We used to teach how to hyperventilate. Are you guys still taught to hyperventilate head injury patients? Why not? All right. So there's 2 trains of thoughts. So with what we were always taught with head injury patients, that we want to bag them really quick and blow off carbon dioxide is what we were doing. But what happens is when you bag somebody really quick and you reduce their carbon dioxide levels too much, then you're actually reducing blood flow to the brain, which therefore is not getting oxygen in the brain, which then kills your patients, right? And so they figure that out. And then sometimes now what they say now, if you have like a true ICP where you have a herniation or something where it's a last-ditch effort to try to reduce that intracranial pressure, then sometimes they'll say to ventilate that patient down. Typically you want to titrate that to like 30 centimeters of water with your end tidal, okay? Or I'm sorry, 30 millimeters of mercury is the reading for end tidal. So we can use that. The problem is if we overbag our patients, say during an arrest, and we're bagging them too much, or maybe we get a ROSC back and we're bagging them too much, we can also harm our patients that way as well. So that's why we need to make sure we're doing slow and controlled ventilations, and that's why we should monitor our end tidal when ventilating the patients as well. All right. The other thing too, if we're ventilating patients that are breathing on their own, or not breathing on their own, but if we're ventilating a patient before their cardiac arrest and we're allowing the end tidal to get too high, we can actually cause some problems there as well. Okay, so we need to manage it based on the patient presentation. Remember, carbon dioxide is an acid, all right? If we think about carbon dioxide and acid, if we leave that level too high and we underventilate a patient, then we can actually cause their pH to get all jacked up, which then makes the patient worse as well. So it goes both ways. A little bit of high carbon dioxide is not necessarily the end of the world. Sometimes it's actually beneficial because with that ICP patient, if we're ventilating too fast, we're reducing blood flow. But actually, if they have a little bit of a higher end tidal, they're actually getting more blood flow to the brain and to the organs. So it's a little bit beyond the scope of this class, but it's something worth looking into. All right, so here's a patient with a head injury. We call them high chaparrals. You know, we got the 475, 75 interchange, and we've got one of the ramps like probably 100 feet up in the air, big, huge hill. So this guy was towing a camper. Him and his wife hit the guardrail, flipped over it, rolled down and down and down and down. Guys got there, patient's unconscious, the wife is semi-conscious, and they're upside down. They need to do an extrication. So how do we manage this guy? Paramedic popped on the end tidal and realized right off the bat that the guy wasn't maintaining his airway very well. Okay, so that's what we see in that top one. We don't see a very good waveform, right? So he's not breathing very well. He opens his airway, which is the second slide. Okay, we're good right now. We can manage his airway just like this. And then eventually they got him intubated and then managed his ventilations, assuming that he had a serious ICP, which he did, and he succumbed to. They managed his ventilations by keeping his end tidal right around 30 to 35 millimeters of mercury. Make sense? All right. This here, EMT, one of our volunteer EMTs got runaway ventilation with one of our ROSC patients. Okay, so make sure that whoever's bagging the patient, make sure they manage those ventilations appropriately, and make sure we keep that end tidal around 35, 45, generally speaking. Okay. If we bag too fast, we're reducing carbon dioxide, and what can happen? Brain injury, right? What's going on with that first waveform there on the top strip? This patient is intubated, being ventilated, and is a cardiac ROSC, or a cardiac arrest ROSC, which we had a shitload of.
Bagging properly, or they have it? Well, yeah, bagging properly.
Yeah, good. That patient was starting to breathe on their own, and you can see that some of those waveforms, you're right too, it could be someone's bagging irregularly and stuff like that, or you're squeezing the bag during the exhalation, right, not managing it appropriately. I'm a fan of ventilators. I like that very much for a lot of things. But nevertheless, this patient was probably breathing on her own and probably needed to be sedated post-ROSC, okay, or needed additional sedation and or paralyzation. All right, you guys have paralytics for post-ROSC at least? Okay, so in your case, you should probably be able to amp them up on fentanyl, manage their pain. What can you give, like 100 mics, 200 mics? Can you give more? 100? All right. I would hit them with 100 mics as much as possible, and you always manage your pain first. So with patients where you intubate them or whatever, and maybe they're having this, if you manage their pain, then you might be able to keep them comfortable. Okay. I'll just ask you. Anybody vape?
Yeah, Nick.
There's always
No, it's not.
there's always one of them.
I haven't done that in months.
Okay, so when you do your tube confirmation. I guess it's better. Were you a smoker before? No. No? So you just started vaping? Really?
You want to be cool like the cool kids.
Yeah.
So this kid's coming around town. He's like, oh, fuck this.
I quit drinking too like 2 days ago.
I drank a lot of beer over the past one weekend, and I smoked a lot of cigarettes, and it really kind of cured my wanting to smoke.
Yeah, you can get it back. I got faith.
I haven't got it yet.
So what are you looking for when you do tube confirmation? How are you confirming your tube placement?
First, I want to make sure you get a waveform.
Okay.
Yeah.
Still
Yeah.
a good sign.
Some people get caught up in numbers first. That's the biggest thing to remember is don't get caught up in numbers. Look for a waveform. Your waveform, I mean, that's grade A, top-notch, best way to ever confirm tube placement. The only time I've ever seen that happen where it wasn't confirmed is a monitor failure, equipment failure. And that was one time in the past 12 years, 11, 12 years that I've been doing it. Okay, and it's an old piece of equipment too. So always make sure to look for waveform. Typically they say 6 ventilations is what you want to make sure of, right? I see 2 or 3, I feel pretty happy, but we're going to keep on monitoring it, okay? Tube in place? No. So this is a nursing home patient. Puke, poop, all kinds of nasty stuff, the typical one that you're not really happy to deal with. And this was new for us, and we had a guy that was an officer that was resistant. He's getting in the way. The other 2 guys know what to do, but he's the one causing problems. They go ahead and intubate the patient and say, we have condensation in the tube. I hear lung sounds, and oh, by the way, there's no waveform. The other 2 guys are saying we need to pull this tube, this isn't right. And the officer getting in the way. I'm an officer too, but you know, it's not always the officer. Sometimes it's a senior guy, it's someone that thinks they know more than they should. But in this case, look at that time span right there when they intubated. So 15 minutes into the call, they go to intubate the patient. Now we're at 22 minutes. Is that good?
Not at all.
But the tube's in. The tube's in. I see condensation. I hear lung sounds, right? Those can all provide very false positives, right? After the guy got out of the truck, they pulled the tube and they bagged the patient. And now what do you see? It's not a monitor issue. Okay, that's why I also advocate bagging a patient with the end tidal to begin with, just because like we did with the CPAP patient, we want to get our baseline. If I pop that end tidal on, I'm ventilating the patient, and I know I'm getting gas exchange, then there should be no doubt whether that tube is in or out when we put the tube in, okay? So they just bagged the patient on the way to the hospital. It's not pretty. They managed it best they could on the way into the hospital. Why didn't this patient arrest after 7 minutes? We certainly weren't helping that patient ventilate. The patient was still breathing on their own. And the reason there was condensation on the tube is because they were breathing and causing the condensation. So the tube was in the esophagus. But the patient luckily breathed on her own. She had a brainstem herniation, so she wasn't in good shape to begin with. But we didn't make the situation better, right? All because of arrogance, all because of pride. These are the kind of situations you can find yourself in the courtroom, right? Yep. Michael Jackson trial. Got called to the stand and, yep. All right. So here's a patient that we intubated. Oh, I'm sorry, this is a cardiac arrest patient. And initial BVM during the arrest. We had a ventilator hooked up. Do we have a good waveform? Are the breaths going where they should be going? Probably not. Adjust the airway. Breaths start going in on the second strip. Those bumps you see are the compressions. Okay, so we're ventilating during the compressions. And then you can see as time goes on, we get the tube in. Actually, those are all BVMs there. But you can see that we had a confirmation our ventilations weren't getting in. Very simple, easy to use that way. Okay. Other patient, you guys have Kings or iGels? What do you use? Kings. Okay, you can use this technology for that as well. Do you guys do that when you're using Kings? Okay, we don't either. So every once in a while we pop a King in. Some places use them religiously. I'd rather have a tube in, but Kings can be quick and easy and something to use as a bridge even when you go to intubate them. In this case, do you see a normal waveform in the top strip? Well, it's a box-like shape.
Yes.
Okay, so in that case, it's a normal waveform. So, but you also see that it's very long. And remember, we're ventilating this patient. This is us ventilating this cardiac arrest. So we have slow ventilations to start with, but we also have a really high end tidal. So now if I'm starting to do my H's and T's during arrest, I can look at this and go, wait a minute, why do I have a high end tidal? So why would I have a high end tidal during a cardiac arrest? Could have ROSC, could have. In this case, it wasn't. But it could be a long downtime, perhaps. Depends on what the long downtime is. But what typically happens, if we have a regular cardiac arrest, we start working on arrest, do we usually see that high of an end tidal? It's usually a bit lower, isn't it? CPR is not the most efficient thing in the world, regardless of manual.
Also respiratory problem?
There you go. Yeah. So this patient may have stopped breathing first, right? We have a buildup of carbon dioxide. The heart was still pumping. The body is still producing carbon dioxide, but they stopped breathing. Okay. Another thing it could have been is like a CHF patient, but we didn't see any pulmonary edema or anything. We found her laying face down. She was a bigger woman. It's very possible that she suffocated herself, went into arrest. And then how are we going to manage that patient now? Is epi the right thing to give? Or is there something else that we can do that's more aggressive that may be able to, actually, no, and I'll go into that a little bit later. In this case, we can correct that by ventilating the patient down, right? If we start bagging that patient faster, we can blow off more carbon dioxide, and most likely what they need is oxygen and ventilation. So I can be really aggressive with that and bag them down. Make sense? What are those bumps there? Yep, CPR. Notice the third one, we have a king displacement. Kings migrate very easily. So in that case, the person owning the airway, right, needs to notice that, be watching the ventilations while they're bagging them. We recognize it immediately. We corrected it a couple times because it kept on sliding, and then last slide is when we finally have that tube placed properly, or the king placed properly.
Medic 1 Tiffin. Medic 1 is in service of mercy.
Nach wie vor, wir haben uns. 7 Minuten geht's noch. Viel Möglichkeiten hat die Austria nicht mehr. Und das ist fürs Faschings Kabarett.
He's faking it anyway, so. All right. So the very beginning of this is a little tough to get through. I understand that. It's a lot of waveforms and strips. It's all very interesting, but until we get to cases, I just want to make sure we established a few things first before we get into cases. So this patient, intubated CPR. Do you see a number waveform in the beginning? This is typically what we'd see in a arrest patient. So we got intubation confirmation. That first breath is, just the beginning. And then we have a nice waveform. We have a nice controlled ventilation. And notice that the end tidal in this cardiac arrest patient is lower. Okay, this is typically what we'd expect from a cardiac arrest, because when we're doing compressions or we have a Lucas device working, it's still not as good as a regularly beating heart, right? We also have to keep in the back of our mind, are we ventilating appropriately? Are we providing appropriate compressions? Or do you guys have Lucas devices here? Okay, so is the Lucas device in the right spot? Is it placed appropriately? Are we getting maximum compression for replacement? Okay, so we think about all these things. Are we ventilating too fast? Are we ventilating appropriately? Okay, check, we got that right. We know we're doing that correct. So why is the end tidal low now? Okay, we're doing compressions. Okay, it's in the right spot. And is it low because it's just low? In this case, I feel pretty good if I got a 20-25 end tidal during an arrest. If it's like really low, below that, then I'm thinking there has to be some kind of there has to be some kind of perfusion issue and or a metabolic issue. Now, what's your name over here? Travis. Travis said something earlier about bicarb, and should we give bicarb to a patient? You'll find a million different opinions whether to give bicarb or not, okay? But when you have a really high end tidal, giving bicarb is going to produce more carbon dioxide. So if you have a really high end tidal, then I'm thinking ventilate the patient down. If I got a really low end tidal, then I'm thinking perfusion or I'm thinking metabolic acidosis, okay? And well, I don't want to go down that bunny trail, but if you look into it, a low end tidal, you can think metabolic acidosis. There's some kind of metabolic acidosis going on versus respiratory acidosis when you have a really high end tidal, okay? Or in the back of your mind, really high end tidal might mean metabolic alkalosis, which you rarely ever find. It's very difficult to correct, okay? So in this case, we have a relatively low end tidal. We're doing all the things we need to do. I think back then this was vasopressin, and we got him intubated, and then boom, we have a spike in that end tidal, okay? Spike in that end tidal, usually around 15 points or so, and we see it goes up to a relatively normal level at about 35. Congratulations, we did it. Ice them, go to the hospital, or do whatever you guys normally do, right? So that's typically textbook ROSC right there. So this patient probably did not stop breathing first. Their heart probably stopped first for some kind of reason. It's up to us to determine what that is. Get ROSC back. Now we're doing 12 leads, and we're managing the patient however we need to do it, okay? Maybe it was a STEMI. Make sense? All right. If it's perpetually low, then either the patient's been really dead, all right? So if we got like an end tidal of like 10, either they've been down for a long time and they're not coming back because they're probably not producing any carbon dioxide anymore because they've been dead for so long, or they've got some major perfusion or metabolic acidosis going on. And in that case, we can treat them with that too, at least give them some kind of chance. But generally speaking, patients that have like an end tidal like less than 10 don't do very well. Okay? But we can treat them aggressively by using this in the context of the patient. You think they stop breathing first? Yeah. Yep. Probably stop breathing first. We bagged them down, and this was another ROSC. We had a buttload years ago during when I was collecting all this stuff. So we bagged them down, got a pulse back. Okay. It probably wasn't the epi that did it. Oxygen and ventilation. All right. Really high end tidal. Do you have a normal waveform in this case? No. This one was normal. This one's not. Okay. Another cardiac arrest patient. This was difficulty breathing. It came in first. COPD. She had an this is one I can't say, Julian. Exacerbation. And we got there, started working her, and ventilated her. Did an inline nebulizer treatment while ventilating her. Hit her with the epi, of course, and then we also did mag sulfate. Got a pulse back. These patients don't do very well because they've been without oxygen so long. They've retained so long. But we did get a pulse back where we gave her her best chance. She ended up not functioning properly in the brain. You know, she just had too much damage. But what's that?
Still a life-saving medal, is that, or?
Yeah, that's right. You guys get medals? Yeah.
Sure. Yeah.
Yeah. So you get excited about those then, right?
Oh yeah.
Yeah.
Super pumped to do.
Get a pin or something.
Thanks for doing your job.
Yeah.
Medic 116.
We have a thing where the mayor would give us a mug. You get mugged for doing something. So then we create our own with a styrofoam cup. We call it getting cupped. So we start handing out our own styrofoam cup. You know, get cupped. Yeah. Which has a double meaning, of course.
Yeah.
But
Don't start doing it.
so did you on these slides here, on this one here, do you see a change in the waveform over the course of time? Yeah. So we improved the situation the best we could. The biggest thing with this is they have a high end tidal, and you might think you want to bag them really fast in these situations, but you got to be careful that you're not stacking breaths and then trapping air and then creating a pneumothorax or something like that. Okay, so
You guys give a lot of mag sulfate then?
we're giving more and more. It's depending on who gives it because our protocols are not A, B, C, D, but there is good literature that says with mag sulfate, the earlier you give it, the higher rate of discharge versus admitting a patient. So a lot of people are afraid to give it. There's no really downside to give it. If you have, in my opinion, any moderate degree of COPD or asthma, you should give it. And the same thing goes with asthmatics and epi. If you get like a severe patient that you don't know you're going to turn around, IM epi will work very well. And I think that's often overlooked, and mag is overlooked as well. So, but yeah. So we talked about a lot of these, right? Use with a bag valve mask. I'm a firm believer in that. We should do that right away. Tube confirmation. We can use it for nasal intubation. I don't know if you guys do that at all, but you can actually use this to detect where you're at with placing the tube, okay, if you think about it. Maintaining proper end tidal levels. We manage that with head injuries. Limiting pauses and compressions. Are you guys stopping to do pulse checks and things like that?
No, not if we have that on.
Okay, so you're keeping it going quite a bit, right? I can't remember, do the Stryker monitors have see-through also? Where you can see the EKG and all that? Do they have that? I can't remember. Yeah, whatever.
I was back here.
So like with the Lucas device going, does the monitor read through the EKG at all? Okay. It's not the biggest thing in the world, but you can go by your end tidal. With that patient I just showed you where we had them intubated, you have your end tidal. You can keep on doing your compressions unless you need to check for VFib or something in shock. You can limit the amount of pause in your compressions by watching your end tidal. If you get a spike in your end tidal, what do you guys do? If you see a spike, do you get a lot of ROSC patients here? It seems like hit or miss. That's good. So if you get a spike in your end tidal, are you thinking ROSC already? Okay. And then what do you do right after that?
Check for a pulse.
Okay. Do you continue out your cycle first? Okay. So you continue out your cycle and then you're checking for a pulse. So we'll monitor end tidal a lot to prevent the pauses, because we know that if we limit our pauses, that we're not helping our patient, right? So if we can limit that by watching the end tidal more, then it's a good thing. Okay, we can go out, gauge that quality of CPR, just like I was mentioning. If we're trying to troubleshoot and see what's going on with this patient, am I ventilating the right rate? Yes. Okay. Am I doing good compressions? Yes. Okay, then why is the end tidal really low? There has to be something else going on, right? And that's where differential diagnosis comes in. All right. Initial BVM. You can see it's kind of low. Here's this little girl, teenage girl, special needs in the high school, and unable to communicate, and doesn't do very well in the library. Goes unconscious, goes into cardiac arrest. I hope I'm showing the right one. Yep. So initial BVM, they're using a BVM, got a good end tidal, waveform, but it's really low. Agree? Okay. We can't necessarily use diagnostic with a bag valve mask, but we know the air is getting in. So they pop a king in, there's some anatomical issues, and get the... Is that you guys?
The medics never can make it back. They're back to service.
This happens to us all the time. Like, it's try to do training and yeah, I can't. Better off duty if possible.
Tiffin EMS, 17 County Request Squad, 442 South Harley Street. 442 South Harley Street, 67-year-old male fallen. 17 County Request Squad, 442 South Harley.
All right, so King Airways in, they couldn't get a tube. There was some kind of anatomical issues. Do you notice that the waveform is really, the number's really low? Agree? It's like 10. So they're bagging the patient. They get the King in. The problem is that with the King, all they see on the monitor is a flat line. So what we see right now is not what they were seeing. Remember, that's it really screwed things up for them, because now they thought that they threw them through a loop. They thought their tube wasn't in the right place, right? So remember that thing I said before about pushing the print button? Make sure you push the print button, because depending on your monitors, I know that Stryker's auto scale, right? So you might actually see a waveform on the screen, but in this case, with our monitor, it did not show up. It's because you're condensed in time, and a lot of the monitors will not give you a waveform when it's under, I say, 9 or 8 millimeters of mercury. All right. So if you push the print button, they would have seen this, and then it wouldn't have thrown them for a loop. Okay. So what happens? They're pulling the King airway. They're doing this. They're doing that. They're getting distracted, and they're not able to focus on what's really going on with the patient and how they can correct it. So what happened with this patient? Well, first of all, why is the end tidal so low? What do you think? What are some things you want to think about, or questions you may want to ask about patient history, history of events? Because now we're verifying. Let's just say we verified. We got a King in place. We're ventilating appropriately, and we're doing appropriate CPR. So we need to start thinking about why the end tidal is really low. She's like teen. Yeah, she was in high school. Special needs, couldn't communicate, and as it turns out, the patient was really had been kind of despondent for the past couple days. But she can't communicate to family, doesn't really complain to anybody because she can't, right? And she's kind of slowly faded away in the side of the library at the high school. What are some of the things we're going to check for during our cardiac arrest? Like, what are H's and T's? So what are we looking for? We got to find out the problem to correct it, right? So what can we think about? Possibly, but I mean, most likely not. Special needs, right? Do you guys check sugars? Okay, so in this case, sugar said high. So what does that mean?
So she's probably ketoacidosis.
She could have been ketoacidotic or non-ketonic acidosis, because in this case, she wasn't known to be a diabetic. However, she couldn't communicate to anybody. She didn't feel good. And if someone is in a ketoacidosis or non-ketonic acidosis, they don't necessarily have Kussmaul's respirations. She didn't have them. They didn't notice anything. But if someone is trying to get rid of those acids, what are they doing? Like, besides Kussmaul's breathing, what's your body trying to do? You're trying to piss off ketones, right? So you get dehydrated. Can she tell anybody that she's really sick? She couldn't. She couldn't communicate that. She'd probably been getting dehydrated over several days. And so she had a really low end tidal, really, really low, because she was profoundly ill, very dehydrated, and ketoacidotic. Okay, so she had metabolic acidosis, she had an acidosis issue, and she had a perfusion issue. Okay, so what's the likelihood that we could have saved this girl by the time she gets in cardiac arrest? Probably not very good. Had we been able to get to her beforehand and we recognize this, we can be very, very aggressive with our treatment. Lots and lots of fluids, right? Trying to correct as much as that dehydration and ketoacidosis as possible. Keep in mind that because we didn't know our equipment, we got distracted, and it took away from being able to do everything for her that we could have, despite the fact that she probably was going to succumb anyways. Okay.
Medic 1-2, Medic 1's on scene, 442 Harley Street.
All right. So aerobic, anaerobic metabolism, hemoglobin, O2, and CO2 transport. Remember that blood circulates, and carbon dioxide, just like oxygen, binds to hemoglobin, right? So if we have low hemoglobin or we have low circulating volume, we're going to have trouble transporting that carbon dioxide as well, okay, from a simple aspect of it. Carbon dioxide latches onto the hemoglobin and circulates back to the lungs and should get dropped off to the lungs if it's making it to the lungs, okay? However, if we're in anaerobic metabolism, what does that mean? Aerobic versus anaerobic. Aerobic is we're using oxygen, right? So we're using oxygen. Anaerobic is we're not. So if I'm jogging in place, I'm using oxygen and my metabolism is able to consume that oxygen. But if I go out and run a marathon, then my body is not able to process that oxygen anymore, right? Because I'm stressing my body so much that I'm in anaerobic metabolism. If you're not processing oxygen, you may not process as much carbon dioxide either. So just keep it in mind. It's a whole other side note. It may come up in a case later on. And in fact, what about hemoglobin? What if a patient has low hemoglobin? This patient was a chest pain patient. And what do you see on your 12 lead here? We got called to a cardiologist's office. She was getting ready, an 80-year-old lady getting ready to have a stress test. Didn't even have her stress test yet, and she's rolling off the table saying that she had chest pain. She came in with chest pain, which is why she was going to have the stress test. And then we get her on the cot, and she's just writhing in pain. And a cardiologist, a good friend of mine, says, yep, looks like she might be having a STEMI, or potential STEMI. She's got all kinds of depression everywhere, right? Don't necessarily see any elevation. V1 maybe looks like maybe a little bit. AVR, do you guys look at AVR? Looks like AVR has some elevation. A lot of times we're told not to look at AVR, but it's becoming more and more of an important thing for a left main occlusion. So typically, what will we do for a chest pain patient? Right. Simple stuff, right? But in this case, this lady had a really low end tidal as well. Her vital signs. Normal pulse ox, normal pulse rate, just rolling off the cot. Tons of pain. Respiratory rate, heart rate. And look at her end tidal. Would I expect for a typical chest pain patient to have a low end tidal, do you think? Like, why would that be? If I had a right-sided MI, I actually might have a low end tidal, because what's going on with a right-sided MI? Where's the right-sided MI affected? Right side of the heart? Okay. So what would you normally expect to see blood pressure-wise with a right-sided MI? low blood pressure because of poor preload. Yeah, poor preload, right? So I would expect to see a low end tidal in that case because I have poor right-sided heart function. Therefore, the right side of the heart cannot pump to the lungs to get the gases off, right? In this case, she doesn't have a right-sided MI. She has broad depression everywhere. So we could be thinking about maybe pericarditis or something weird like that. In this case, it could be. In this case, it turned out, and you wouldn't know this beforehand, but it's something to think about because what we, of course, you're inclined to give nitro, you're inclined to do all those things, but is it going to fix the problem? Something's causing this chest pain, and I don't think it's cardiac chest pain, in my opinion, right? It could be a PE because if you have a PE, then you have a shunt, so you could have a PE, so that's something to think about, right? In this case, it turns out that she had low hemoglobin, and hemoglobin carries oxygen. And if oxygen can't get to the heart, it's going to cause pain. And the only thing that was going to correct that is to improve her hemoglobin and probably give her oxygen. So if we were to give her nitro and hit her hard and try to drop her blood pressure, the question is, and it's more of a rhetorical question, are we helping her or are we hurting her? Because if we're dropping the blood pressure more and we're reducing blood flow to the heart more, but she's already not getting oxygen, are we actually helping the patient or hurting them, right? Right. So it could be a little bit of a ballsy move, but you can probably get critiqued at the hospital. Why didn't you give nitro and aspirin or whatever else? I would give aspirin still, of course, but in this case, I think we gave one shot of nitro and said, we're not going to give it anymore. Okay. So just something to think about, and this is really more of an illustration of the physiological aspect behind it and understanding what you're looking at with the context of your patient and thinking about why are these numbers wrong. And I swear by it, the end tidal versus any other vital sign. I rarely care about blood pressure anymore as far as a main diagnostic criteria for different types of patients. I'm always looking at end tidal. All right, perfusion. Here's your first case. This is where it starts getting interesting. I'll let you read the screen. This patient's laying on the fetal position on a couch. So history of events, patient works second shift. He's gets home, eats some dinner, feels pretty good, wakes up in the middle of the night, and starts puking and shitting his brains out. Just all of a sudden, just like that. Laying on a couch, fetal position, 30-year-old guy. And he has no real significant medical history. Had no previous illnesses, though he did mention something about having a recent meniscus tear and surgery for that. And other than that, he had a bout something like this a long time ago, and he had a little bit of mild kidney failure. So here's our allergies, vital signs, and meds. Anything pop out to you guys here? Anything odd? What do you think about pulse rate? Not a big deal. Not usually. Blood pressure? Look bad? Not bad at all. 120/80, not far off. 30-year-old guy. Okay. Did a 12 lead, did our due diligence, nothing on there. Glucose looks pretty good. We check glucose in just about anybody, regardless of diabetes. So what are you guys thinking with this patient? And most of the time when I illustrate this patient, I picture people say, this guy's a pussy, this guy's a wuss, get up. Sorry if I'm not going to offend you, right? She had this look on her face like, no, but 30-year-old guy, get up, walk to the cot, you're fine. Your vital signs aren't that bad. Let's take you to the hospital. Well, in this case, we just started using our end tidal. What do we have here? Low. What's it supposed to be? 35 to 45. So what could be going on? Is he breathing fast? No. Respiratory rate is 16. Not fast. Okay. He doesn't look like he's having any heart issues, so what else could be going on?
Ulcer.
Well, think about what was going on to begin with. Vomiting, diarrhea, right? So he could be profoundly dehydrated. Is there a chance he's having an allergic reaction or something? Still very possible. That's part of your assessment, right? But we know that he's profoundly dehydrated. Did anything else, as far as those vital signs, did anything else like jump out and say a little low? So that could mean poor perfusion, potentially, and sometimes, depending on the time of year, maybe we're just reading bad, right? Depending on the environment or whatever else. It gets frustrating. Yeah, what kind do you guys use? Like tympanic or temporal?
We've had those, but we also just kind of revert back to the oral thermometers that are terrible.
We started using the temporal ones, and they work really good, except when you have temperature extremes, or if someone doesn't keep the medic warm, then all bets are off.
Scan the head but not touch the patient.
Do you have those, or?
Yeah.
Oh, really? Ours you go across the artery right here, temporal artery. Sometimes they work, sometimes they don't. It's kind of frustrating. But, so yeah, so low end tidal. So in this case, this is the only thing that really popped out to me, or to this patient. So what does this patient need? Fluids. Lots of it too. All right, a 250 bolus is what this patient really got, and probably didn't help him much, and so they stroll into the emergency room, and they pass over the patient, and then emergency room promptly takes a cannula off, throws it in the trash, and doesn't really pay attention to the end tidal level, and the patient sat there, and of course the patient gets blood draws and whatever else. Does that take a long time? Yeah. So meanwhile, that patient sat there, probably had an IV TKO, and what happens? Well, it turns out this patient ends up going into renal failure. Goes into renal failure. We could have gave more fluids. The hospital could have did a better job. But this, again, nothing else in those vital signs popped out except for that end tidal level. So that's where it's very valuable to be able to bolus fluids and change and check and whatever else. Okay, tons and tons of cases like this. Perfusion is a huge thing with these cannulas. All right. So how does it work? We're firefighters, so sometimes this kind of thing helps. You got a fire pump. Everybody here an engineer? If I take a take an 1 3/4 hose line and I just kind of take a cross lay and connect it back into the engine, all right, and I start pumping that cross lay. If I'm going to try to flow, what's a combination nozzle? 100 GPM. If I try to flow 100 GPM, what is my pressure going to be at that engine? Like, that's usually what everybody says. Like, yeah. So let's say 150. Okay, 150, or you guys say 135, whatever it is, right? So if my tank starts getting low, and I don't have a hydrant, let's just say magically water's not there. Okay, the tank starts getting low, and I don't have enough fluid to fill up that hose anymore, or to pump. What happens to the pump? It's going to start cavitating. Okay. And if I can't hook up to the hydrant and I need to do something, what can I do to prevent my pump from cavitating and still supply water? Okay, gate the valve down, so reduce the flow. Okay, so if you reduce the flow and keep the same hose line the same, am I still maintaining the amount of GPMs I need? Smaller hose. What if I increase the pressure with a regular hose? Is it going to help the cavitation issue? No, so I have to squeeze down, right? That's where I'm getting at. So, okay, let's say a booster line. So now I can put a booster line in. But in order to run that water through that booster line, can I use the same amount of pressure? No. I have to boost the pressure in order to get the water through to maintain the flow, right? If I took a 2.5 inch and the same amount of water, am I going to make things better or worse? Right. All right. So in my mind, why I don't like blood pressure is sometimes when you have a really sick person, the blood pressure will actually stay the same, or it may even actually increase, because based on that same philosophy, your body's trying to squeeze down. And I think we're taught to think of blood pressure of something then different than what it actually is. Okay. Notice here you have GPMs in the hose, right? And then you have hose diameter. Those two things affect what your blood pressure is. Blood pressure is just kind of like a side reading. And we look at blood pressure almost like it's a measure of the hose diameter. And it's not. Okay, that's actually systemic vascular resistance is what the hose diameter is. And I think we're taught very poorly that blood pressure is telling us systemic vascular resistance. It's not. Okay, so blood pressure is our PSI. In this case, perfusion is our GPMs, and our hose diameter is systemic vascular resistance. Okay? What the end title is doing is giving us direct indication of the GPMs, or the perfusion, versus blood pressure is really just an indirect relationship based on what's going on with perfusion and systemic vascular resistance. You got a patient that's trying to compensate their systemic vascular resistance, they squeeze down, they create a booster line. Okay? You got a patient that's collapsing, their vascular tone releases, and now you got a 2.5 inch line. Okay? So depending on the type of patient you have, yeah, you might have low blood pressure, but I'd rather get to that patient before they have low blood pressure. And the only way I know I can treat that patient is if I look at the end title and use it in the context of that patient, and now I can start treating them instead of just based on blood pressure. I can say, yeah, there's something going on here. I can start being aggressive, and I can actually provide that benefit. Okay? Does that make sense? Okay. All right, we already went through this, so let's talk about this with our patients. We do our initial impression, sick or not sick. That 30-year-old guy, did he look sick? No. He didn't. So we got to be careful with that, making our doorway diagnosis and passing off something as BS. So that's why we put the cannulas on a lot more patients than most people probably do. Okay, very valuable vital sign. Evaluate the waveform, evaluate the numbers, VQ ratio, is it high or low, what's going on, and then we look at those trends or changes. So here's a diff breather for you. See if I can get to my notes page here. All right, diff breather. I'll let you read that. Can you picture that patient? Short and stout, 70-year-old female. What's that?
I didn't say anything.
So she's sitting on the couch in the forward position and says she needs a mask. You think she's been on a mask before? Yeah. What does that probably tell you right off the bat? Been through this before. Maybe a history of CHF. Husband's kind of sitting in a corner. He doesn't seem to be too alarmed with his wife's situation. He's been here, done that, right? Onset difficulty breathing, sudden onset, history of CHF 1 year ago, and by the way, she's a diabetic. And the husband mentioned something about, oh yeah, she's been having some heartburn for a week or two. Okay, so now, do we feel pretty good about CHF walking in the door? I felt pretty good about CHF walking in the door, just knowing that we're probably going to go down that route. So we hook up, we're getting our mask ready, we're getting all of our vital signs attached, and we're getting a cannula on to begin with. And we hook up the cannula, and we're assessing the patient. We notice lung rails all fields. And here's some other things for you to notice. Again, this is very early on, so we don't have everything yet. Then we get our vital signs. We get our end tidal on. Look at our vital signs first. We got a high pulse rate. Look at the pulse ox, how low it is. High respiratory rate. And our end tidal is not too bad, is it? No. But she's got a really high respiratory rate. So something doesn't seem right there. I would expect with a high respiratory rate to be really low. So look at our waveform. Does our waveform look very pretty? What are we missing? Plateaus. So we're missing plateaus for some reason. But what am I suspecting walking in the door? CHF. So why would she have no plateau in CHF, potentially? It's not always the case, but why would she not have it? Full exhalation. Remember, you don't have a plateau, they're not getting full exhalation for some reason. In her case, she's full of fluid, right? If she's full of fluid, is she going to be able to get good breaths? No. So that's why we need to help her with forward blood flow, giving her nitrates, maybe captopril if you guys use captopril. No, just tons of nitro works really well, right? Tons of nitro, CPAP, also giving that forward blood flow. We get her on CPAP, and things seem to be going well. We still have her on a couch, and then we had her stand up and just pivot to the chair or to the cot. And that's when things seem to not go so well after that. So we're moving out to the truck, and this is the application of the CPAP, so we're feeling pretty good about ourselves. Do you feel pretty good? I got a plateau. She's, So blood pressure is really high, so justifies my use of nitro, right? I can hit her all. I'll rather just spray a bunch to start with and then get the mask back on. But because every time we break that mask, we're breaking the seal and making things worse. I'd really like to get like IV nitro or something. But so anyways, Pulse ox is improving. I'm feeling pretty good. This was my patient actually when I used to ride on the medic. End tidal actually raised. Why did it go up a little bit? Remember we didn't have the plateau before, right? So now we're splitting open, and it's actually showing effectiveness of the CPAP because now we're getting a true waveform and a true indication of what her end tidal actually is. So her end tidal was kind of falsely low because we didn't have that plateau. All right. So just little things to look for. And so yeah, this is about the time we pivot her over, get her moved to the back of the ambulance, and then this is what we see as we're in the back of the ambulance transitioning over. Do you see a change in the waveform? How easy is it to assess a patient and ask them how well their CPAP's working? Woo, yeah, you try talking and everything. Now you can look at your waveform and see what the changes are. So this patient's struggling to breathe. Do you think her waveform has improved? No, it's gotten worse, right? So why do you think it's getting worse? So we check all those things, right? Could it be the cannula that got displaced or something? Okay, we check connection, make sure it's all good. Could it be from turbulence from the CPAP? Some people say yes. I don't think so because you got a cannula on right here. So it's highly unlikely that your CPAP's going to cause it. So now I have to look at respiratory effort. And in this case, her respiratory effort was going to shit. She was so far beyond where she needed to be that she was starting to decompensate in front of us. All right. So up to the point that she almost stopped breathing completely. So then we had to try to ventilate her. Is it easy to ventilate a patient that's short and stout and full of fluid? No. So it became a very, very, right. And you really want to lay this patient down to begin with because they're big and then they're creating more pressure in the chest by laying them down completely. And we're trying to actually teach people now in our place to more of a 20-degree angle. I don't know if you guys do that or not. It actually helps with ventilation to keep them in that angle when you're trying to ventilate patients. Helps with CPR, with heads-up CPR and things like that too. But nevertheless, this is a big pucker factor because now we're trying to bag this lady and we can't get her bagged. We're getting her intubation equipment ready. In hindsight, this would have been a good case where we could have, she had a small mouth by the way too, so that really didn't help things either. Small mouth, no neck, typical like perfect worst case scenario. And in hindsight, we could have popped a king airway in and helped her. We didn't. We ended up having to intubate her. And luckily, we got the intubation. And when we get the intubation, we also do a 12 lead. There's your 12 lead. What do you see?
Medic 1, Tiffin.
Okay, where do you see elevation at?
Medic lines arrived at Tiffin Fire.
Mm-hmm. So anterior left side of the heart. Okay. LAD, occlusion, which would fall in line with left-sided heart failure. Okay. So she probably had left-sided heart failure, typical CHF patient, and was having an MI and poor heart function on the left side. So it all fits together, right? So pucker factor goes, we intubate her. That's when we're trying to bag her. Are we getting ventilations in? Oh, no, this is a bad situation. We got a hypoxic patient that's not breathing on her own, and we're trying to ventilate them and can't. Like, we're lucky she didn't arrest in front of us, right? Get her tubed, and this is what we have. What do you see? Good waveform, okay. Yeah, we got really high end tidal now. Did we have a really high end tidal before we tubed her? No. Aside from the crappy waveform, we're not going to get a good reading there, right? But when we got her on CPAP initially, we're sitting around 35. So what do you think happened there? Why is she so high all of a sudden? Probably partly from that because you're ventilating more effective than she was. And then also remember, she stopped breathing and we weren't doing anything for her. She was building up. So she was probably a butt hair away from arresting, okay, along with poor oxygenation. So you can see her stat got as low as 53 when we tubed her. That is not good at all. We got her up to around 90s. Do you guys use PEEP on your bags or ventilators? Positive end expiratory pressure, it's a little valve. That's something I would look into because if you think about it, CPAP is pretty much PEEP, okay? It's continuous positive airway pressure is what it's supposed to be. So if you have to tube somebody, just about every patient should be on probably 5 centimeters of water of PEEP, which is equivalent to, a lot of guys don't do it, many places don't do it, but it's something maybe you should look into. In this case, it was very effective for her. The problem is that we overventilated her, and because you have PEEP, you're reducing the amount of air coming out, you're slowing things down because you're maintaining pressure in the lungs. We provided better gas exchange, but we also were trying to blow off that carbon dioxide, okay? Based on this patient, CHF, are we going to, with the left-sided heart failure, are we going to ever going to be able to blow off enough carbon dioxide to get her low? Probably not. So this type of patient, looking back on it, not worrying so much about trying to get her end tidal level down versus managing the ventilation and the heart failure aspect, so much that one of the guys, it was a great idea, we get her tubed and we have spray nitro, and we just started spraying it in her mouth and bringing down her blood pressure, trying to promote forward blood flow using the PEEP and managing her ventilations. In my case, I was actually managing the ventilator. I was ventilating her way too quick, and I started stacking breaths. I don't know if I have a picture of this or not. I don't. But if I started stacking breaths, I'm going to start seeing a rising waveform, our baseline, right? So just keep that in mind. As we want to have that goal of 35 to 45, but it's not always attainable. Okay. You guys need another break? No? If you need to, stand up, move around too. All right. Asthma attack. 65-year-old female sitting on the ground outside Indian style. She was of a different language, Asian Indian, so we couldn't speak to her, but she's in obvious distress. Her son, who is bilingual, says that she has a history of asthma, and she had a sudden onset of working while working and cleaning. Okay, history of asthma. So here's your initial vital signs, and as we're trying to assess, which we have a language barrier, we can't understand what she's saying. We're trying to go through the son. All we really have is what we know. But we also notice on the lung sounds, the first assessment of lung sound says, the care provider says, or the assessor says, I hear wheezes. So we hear wheezes, we look a little bit closer, and here's some of her vitals. What do you see popping out in the beginning at 609? 609, 610. SpO2 is low, okay, so that could be a myriad of things, right? Respiratory rate's really high. Pulse rate's really high. Okay. Does it tell us anything thus far, like telltale? If someone says, I have asthma and I have an asthma attack, or this person must be having an asthma attack, a lot of times that's what we kind of program in our minds, is we start thinking about what we're called for. Well, they got a history of asthma. We think we hear wheezes. It must be what it is. Okay, so let's couple that with our end tidal readings now. Do you see a bronchospasm? Looks relatively normal. Maybe a little bit of a slight curve on that front there. Is it consistent all the way across? The waveform is relatively consistent with that. Yeah. Okay. If I didn't just tell you all that other stuff, and we looked at this waveform, would you think this patient's having a major asthma attack? No. No, right? So, but this patient's breathing 30, 40 times a minute. There has to be something else going on, right? So if someone's having a major COPD or asthma attack, we're going to expect a major shark fin, right? Because it's going to encompass the entire portion of the lung. If we got a minor bronchospasm, like this one, or potentially minor, and I would even maybe question that a little bit, then I would expect just a minor asthma attack. So something isn't right. So then we listen to lungs again, and somebody else says, well, I hear cardiac wheezes. You guys ever hear of cardiac wheezes before? Have you ever heard that term thrown out there? No? Sometimes we can, what's that?
I have, but I've never heard it.
Okay. So cardiac wheezes is in a CHF patient, and we think we hear wheezes, but it's actually fluid that's causing the wheezing kind of sound. Okay. So if you can look that up, there's a few GEMS articles or EMS World articles that talk about cardiac wheezing. And it's an area where we can easily get tricked into going one route versus another. So initially this patient started getting treated as an asthmatic. Based on what you're seeing with the waveform here, would you say that's Good, bad, the only thing to do here? What do you think?
Well, it's not bad.
It's not bad.
Yeah, you're not
There,
hurting anyone.
there's a chance that she is having a mild asthma attack, but are we going to fix the problem?
No, you're not gonna fix the problem.
No, but it might help. Okay, so what else could be going on here? We did an EKG. I don't have it on here. EKG was showing some elevation in the anterior leads. We thought now we heard cardiac wheezes, and we know we're looking at a waveform, and it's not matching up as a true asthmatic. She was slightly diaphoretic. We kept her on nebulizer, but we also hit her really hard with nitro, and we put her on CPAP with the nebulizer. And we got to the hospital, and she's laughing and feeling good. So much that the doctor was going to write her off as just being a cured asthma attack. And she actually did get discharged, but got readmitted. I never quite found out why she got readmitted. My guess is because she was having an MI, and it got masked. But I don't know for sure. But nevertheless, we had a really high blood pressure. The waveform, that's why you always want to use this in the context of your patient assessment, okay? You guys just do a 12 lead and go, this patient's not having an MI. 12 lead's normal. No, you don't. You never write that off. And the same thing goes with this. You have to think about that ventilation, perfusion, metabolism. Think about all three of them play. All right. If I had a severe respiratory distress asthmatic, physiologically, they're going to be slowing down their respiratory rate because they can't get air out. They're going to have a worsening bronchospasm. So this level of distress does not match that. And remember what I talked about with the CHF patient? She has a high respiratory rate. She has a backlog of carbon dioxide because her heart can't pump forward. And so therefore, she's going to have a relatively normal end tidal along with her high respiratory rate. Okay? Confusing? This stuff takes time, and you're going to have to just keep on using it, but you'll notice over time that it's going to make sense more and more. All right, so here's another patient for you. 05:31 in the morning, 74-year-old male, sudden onset difficulty breathing, audible crackles in the bases. What are you thinking? It most likely woke him up, right? What do you think your potential problem might be? It might be a CHF early in the morning, right? That's a lot of times what I think. And personally, what I've always thought coming up through EMS, well, it's got to be either COPD or it's got to be CHF. To me, that's like my two things that I've always thought, right? Or what else could there be, right? As we've evolved in EMS, I think we start adding a few more things to that list. And then how do we navigate through this stiff breather and figure out if what we're doing is correct? Because let's face it, if I hear there's audible crackles in the bases, I might be thinking CHF. I think most of us probably will. And I'm most likely going to treat that patient as CHF. I'm also going to look for other signs and symptoms. So let's see what we have. So here's our vital signs. Do you have anything else that's pointing potentially towards a CHF patient? Hey guys. Do you want us to start over?
Yeah, please. High blood pressure, high pulse.
Okay. Yeah. So we got a bunch of problems, right? 12 lead flags STV, but it's probably not SVT. But yeah, 146 pulse rate's pretty fast. So this guy has a history of a bunch of different stuff. He has a history of COPD. He has a history of CHF. He has a history of this, history of that, hypertension. He's your typical patient that is confusing. So is there anything here that makes you think, okay, maybe it is CHF? What do you look for with a CHF patient? Pulse ox is low, so that would be one thing to look for. Earlier we had CHF patients with really high blood pressure. Does he have that? He has it. Blood glucose is maybe a little high, but not bad. I can't remember if he was a diabetic. It's very possible he was. I would say probably was. So, what are some things maybe nowadays that would be missing, or what are some of the things that you would assess for? Obviously,
Fever.
Okay, good. Why would we assess for a fever?
Pneumonia.
Okay, good. Do you guys regularly check for fevers then? I used to think that was a nurse's job. I'll admit it freely.
Not unless you actually feel them.
We've gotten much better with it. I think we've come to realize that it's very important. What happens if we're thinking CHF and it's actually a fever? There's a fever. I mean, do CHF patients typically have fevers? No, there's got to be some kind of infectious process, right? So that leads us down a different path. In this case, a fever was present, and the temperature wasn't taken on this patient, and so we're thinking CHF all the way, and then got treated like CHF. And as a matter of fact, we've had this patient several times over the past few years. This is rather old now, so over the course of a few years. And just about every time, he got treated as CHF. But there's a little thing that I've learned to look for to help navigate aside from fever, right? Do all pneumonia patients have fevers, though? No, they don't. And just to give you guys a recap, with CHF patients, I'm going to have a really high respiratory rate. I'm going to expect a relatively normal waveform, which is odd because normally if someone has a really high respiratory rate, I'm going to have a low number for, say, a hyperventilation patient. All right. So I would expect if this patient was a CHF patient, I would expect him to have a relatively normal end tidal. It turned out his end tidal was 24 and normal waveform. So he's got COPD. I can knock that out. Okay, it's not COPD most likely. Is it CHF? He's got an end tidal of 24 and it's normal waveform. Probably not. Oh yeah, and by the way, he's got a fever. Remember earlier I said fever produces carbon dioxide? It's metabolism, right? Hypermetabolism. So it produces carbon dioxide. Also remember very early on, ventilation, perfusion, metabolism. We got a few things going on here. He's breathing fast, right? Breathing fast, and he's got a low end tidal. That can be contributing to it, right? Do pneumonia patients oftentimes have perfusion problems? Yeah, a lot of times they're dehydrated to begin with. So if we started treating a pneumonia patient like CHF, we're going to further dehydrate them and perpetuate the problem, right? So we could have a perfusion problem going on here. And then he has a fever, so that's a metabolic issue also. So in the case of ventilation, a high ventilatory rate and a low perfusion, we're going to have a decrease in our end tidal. Okay? But wait a minute, we got metabolism and a fever over here. So it's kind of like a competing thing if you think about a little balancing act. All right. So what I look at, in this case, this guy had an end tidal of 24. But I got this hypermetabolism going over here. So it's actually kind of falsely elevating my end tidal. So if I didn't have a fever, I'd expect this guy to have like 20 or maybe a 15 end tidal. And that just puts it in perspective for me. Okay. Helps me put it in perspective and think about how sick this guy really is. So another little tidbit for this guy had some bloody sputum. So some bloody sputum. When do we normally have bloody sputum? What's that? They could have an emphysema or COPD patients, right? And in this case, sometimes pneumonia patients, especially, and then COPD patients are oftentimes succumb, or are, succumb is not the right word, but COPD patients oftentimes will get pneumonia. All right, they have all that gunk in their lungs and everything else. It gets trapped. So the bloody sputum could be an indicator, again, of pneumonia. So a couple of things that we missed, but coupling that with the end tidal, if I got a high respiratory rate and a low end tidal, it ain't matching up as a CHF type patient typically. You know, it could be a cardiogenic shock, right, because of right-sided heart failure problems, but not necessarily a true CHF that we're accustomed to. Does that make sense? We did measure lactate, and it's at 2.6, and he had a temp of 100.4. Okay, you guys familiar with lactate? For sepsis? Okay, we'll talk about that in a little bit. All right, so this case, the guy actually, I've seen him after the fact, and I asked him about all his different, because it's always tough to find out about our patients. It just never works out very well. And it turned out we saw him in a nursing home, and he had heart surgery. And we went to see him, and I was talking to him about his different occurrences. And he's like, yep, I had sepsis. Yep, I had pneumonia. Yep, I had this. Yep, I had that. Never once did he say CHF. So this fits in the picture of that. This was him on a different day. And I won't go into it, but you'll notice that, well, this guy, he was treated as CHF. So what do you get when you put someone on CPAP with CHF? What are you putting the pressure at? You have a pressure setting that you set for CHF versus, say, COPD or asthma?
Peak level of like 8, but on ours we don't have like,
What do you guys use?
we got that Ohio adapter, so it's just constant flow from the.
Constant flow?
Tank, yes, yeah.
So what do you do for your, do you use CPAP on your asthmatics and COPDers?
Not very often.
No, it's not in your protocol?
If they ask for it,
Uh-huh.
a lot of times we'll give it to them.
But it sounds like yours is a constant flow. It's not like you can adjust the pressure, right?
Used to be able to, but
Because typically it might be hard at a higher pressure to get your nebulizer to go in, even if you gave a nebulizer with your CPAP, right? Okay. We use flow safes. I don't know if you ever heard of them. But we use flow safes. Some people use whisper flows. And so you can incorporate the amount of pressure based on the patient presentation. So COPD and asthmatics, you might use 5 centimeters of water. CHFers, you typically use 10 centimeters of water. So this guy was treated like a CHF. He was given nitro and he's given everything else. So if you look at the waveform right here, waveform is around 35 to start with. Agreed? And as time goes on, is his waveform improving? It's not. And look at the very bottom. So what do you think's happening? CPAP's not helping. Something ain't working. So in this case, we're treating him pretty heavily with the higher pressure. He's probably, well, he definitely was pneumonia in this case, okay? We're treating him like a CHF. We're giving him nitro. We're doing all these things to probably worsen his cause. And then he's not handling, he's so tired that he's not handling the CPAP either. So in this case, his pressure is dropping, his respiratory effort is dropping, and it's showing on the waveform. Remember, our end tidal is going to show from 2 things regarding ventilation: rate and tidal volume, right? So his rate's pretty good, but his tidal volume's starting to go to shit. And I did follow up on this case, and he did go into respiratory failure. He was in respiratory failure here and continuing out the hospital, ended up being intubated. Okay, so look for those little signs and clues that, you know, again, "Whoa, how you doing? Whoa!" You know, you can't communicate that very well. So now you can see it. All right, remember I talked about shunt, physiologic shunt. Remember I said how oxygen and carbon dioxide cannot exchange. It's a complete roadblock. Okay, you got a VLI that are blocked off. I said that very early on. This gentleman was in severe respiratory distress, likely had acute respiratory distress syndrome. I don't know if you ever heard of that. But essentially, he had a physiologic shunt. So gas cannot exchange one way or the other. Do we have a really crappy waveform here? Yeah, especially the first one, right? Now, if you look at this first one, you'd think that that guy wasn't breathing at all. I'll tell you that this guy was in full-out respiratory distress, and he was moving plenty of air. So he had good tidal volume and he had good rate. But why does he have a shitty waveform? Yeah, physiologic shunt. So the gases were not transferring to the alveoli because there was a complete roadblock between the alveoli and the capillaries, okay, and a very large portion of the lungs. Typically, that is like the very severe respiratory distress patient, and no matter what you do, you cannot get their oxygen levels to come up. Remember we talked about that early on? A physiologic shunt, okay? So that waveform was really crappy. We put him on CPAP and added, I think we might have added oxygen underneath with the cannula also. And we did improve his pulse ox, but however, it was only going up to about the 80s. I want my patient to have at least 90%. I think most of us probably do, right? But we could not get it to go up very high. But notice the waveform did improve a little bit, right? Got a little bit more consistent. So that means what our treatment was helping, right? We were providing CPAP, which is expanding the alveoli, promoting more gas exchange, and the oxygenation levels were going up too. So we had improved gas exchange because we're providing the CPAP and the oxygen. Make sense? Is that a nice looking waveform on the bottom? Better, and it's consistent. So then we start thinking about what else is going on. Well, we know we got a physiologic shunt, so that's part of the reason why the waveform looks so shitty. Well, a nebulizer treatment work can't hurt, in my opinion. So maybe you can give a nebulizer treatment. And then you also have to start thinking about what else could be going on. Ventilation, perfusion, metabolism. We already established we got a ventilation issue. Could we have a perfusion issue with this type of patient? He's a nursing home patient, really sick, respiratory distress. lungs are just pure shitty. What else could be going on with this patient? Somebody said it earlier with the other, yeah, right? So it's a very good chance he could be septic. So now we start thinking about the perfusion aspect as well. Maybe we're going to treat with fluids or something, okay? So again, in the context of the patient, you just can't look at a strip and go, this is what it is. Think about your patient, how they're presenting, and apply it. All right, good case. Called the residents, difficulty breathing, and back pain. En route, we're told the patient had a history of a kidney transplant. And when we get there, the patient is in, the friend meets the patient, or meets the crew at the door, and it's a 42-year-old female. She's in the recliner, semi-reclined, alert and oriented, labored respirations, and semi-complete sentences. So there's the chief complaint, mainly back pain, flank pain. She said it was onset of 9 o'clock this morning, no provocation, so no exertion, no trauma, no nothing. Quality was none specified. She said it's somewhat radiated to her upper back, and she said it was severe 10 of 10. It was somewhat positional, but not complete relief when she was positioning herself. She even tried heating packs and stuff like that. Nothing seemed to really work. So the patient's legally blind. She has a history of kidney transplant 6 years prior. Right? So she has one functioning kidney, which is the left kidney. The right kidney is non-functional. She said that she does have a little bit of a productive cough, which we noted during the course of treatment, but she's like, it's kind of normal. That's what she says. She says she has sinus congestion. That's what it is. So digging a little bit deeper, we notice she has a fistula on her right wrist, but she's not a dialysis patient. But she does see her doctor regularly, nephrologist, for her kidney issues, right? So she had just been at the transplant center a week ago, and she was complaining to the doctor there and the staff that she was having difficulty breathing, dyspnea on exertion, and fatigue for quite some time. So the doctor decided that she had some swollen ankles, so he decided that she needed more Bumex. You guys know what Bumex is? Yep, basically Lasix. Same thing as Lasix. So he gave her Bumex because if you have a patient with one kidney or have issues of kidney issues, is it good or bad to be retaining fluid and not peeing? It's not good, right? You want to keep the kidneys functioning, and you keep that functioning by keeping them peeing. So he did what he thought was right, and he noticed that creatinine levels, I think, were relatively normal, so he didn't think much about it. Okay? But now we're faced with this patient, and here's vital signs. What do you guys see on this? Respiratory rates high, labored, end titles low. Temperature's high. Okay. Is this going to be changed, or is the Bumex really doing what it's supposed to be doing? No. So it's not as simple as that. So something was going on when she was at the doctor's office and hadn't completely surfaced, or perhaps it did surface and it got missed. So what do you think is going on? She has core is hot and dry. Her lungs are clear and equal. She has these labored, when she has increases in pain, she has labored breathing. Any ideas?
UTI.
Could be. Could be UTI, right? It could be. She also had a productive cough. How often are we spot on with our lung sounds? It's a pretty subjective lung sounds, right? I mean, you can have 5 people listen and everybody come up with a different answer, right? So I think I listened to lung sounds on her. I didn't hear anything. But she did end up becoming a pneumonia patient, right? Amongst other things. So what are the additional factors with the assessment? Arthrostatic vitals, sitting to standing. We didn't need to do it because her end total in my mind was 14. And I didn't mention this before, but typically your cutoff for saying I'm ready to treat relatively aggressively on that perfusion patient or someone that has a suspected low perfusion is about 25. So normal expected end title is 35 to 45. All the literature basically says 25 to 28 millimeters of mercury is a good place to start treating pretty aggressively. So this lady had a 14 end title, and she had a fever. Remember what I said about fever? Kind of masks it, right? So in my mind, pretty high fever, she probably had an end title of 15 or 10. If you had a patient in a cardiac arrest and had an end title of 10, what would you think is... You think that patient's going to have a favorable outcome? No. So we need to work hard. Well, the problem is the blood pressure wasn't that bad, was it? What was it?
110.
110.
Yeah, 110 over 70. How many people would treat aggressively 110 over 70? No.
Based on your blood pressure, if you did put the end-tidal on, you'd be,
Right.
it's not that bad.
Right. So to me, it puts it in perspective. This lady's really sick. So we have 10-minute transport to St. Luke's. And 10-minute transport, I got in 1,500 of saline. And I actually did get a purposeful response in her, but also her end tidal. And ironically, her blood pressure dropped a little bit. So remember we did that fire truck thing, those of you guys that were here? In my mind, that actually justifies that type of theory is you can actually have a blood pressure drop when you improve perfusion because they're not clamping down as bad. Just a theory, though. But what ended up happening, we get to the hospital, we get a hall bed. I said, this lady needs a room. And we were just starting our sepsis protocol. Do you guys have a sepsis protocol? This was technically our first sepsis patient, though a protocol wasn't active yet. And we notified the hospital, said, I think the patient's septic. I think we even called a sepsis alert. Sound the alarms, the whole 9 yards. And Nurse Molly puts the IV TKO, says, okay, thank you very much. I said, I don't think you want to do that. I think you guys need to get her a room. She's going to crash. And okay, thank you very much. And she just sat in the hall bed there, and she didn't look that bad. And that's the whole point, is a lot of these patients don't. Sometimes we get to the point where we think if the patient's not dying in front of us, actively dying, that they're not that sick. And we tend to get a little tone deaf with regards to how these patients are actually presenting. And a lot of these things are very cryptic. And that's what the end tidal does, is it takes care of some of that cryptic stuff and helps really reveal what's really going on. So we had an improvement of end tidal up to like 22, something like that. We had her in Trendelenburg position, had some good improvement, but guess what? She sat in the ER. She didn't really get any more fluids. And of course, they're going to draw for labs and do all the other bullshit that they do. Oh, and by the way, her blood pressure is really good, so we're just going to monitor her for right now. Well, she ended up going into what's called multiple organ dysfunction syndrome. Do you know what that is? It's when a patient's really shocky and they don't get treated for a long time. And her organs were not getting oxygen. She already has one bad kidney, and right? Yeah, and her kidney's not getting oxygen. She became very, very ill. She probably almost died. She actually was one of our charity people later on for Christmas, so I got to talk to her, which was really cool. But her blood pressure dropped down to 60 over 40, maybe even worse than that in the hospital. I might have the notes in here somewhere. But it's complete bullshit. It's complete bullshit that we can, even us, finally notice this stuff and then treat our patients and be aggressive about it and not have to follow through at the hospital, right? So we at least can do our part and start being more aggressive with these types of patients. It's not necessarily, low end tidal is not necessarily exclusive to sepsis, but it is to perfusion type issues, right? So, and I hate to say that I've seen this happen time and time again, where we sound the alarms, we say this patient's going to crash, everything is saying it, but they're so focused on blood pressure or whatever else, okay? And that's why I don't like blood pressure. So yeah, there's our arrival. We got the end tidal up to 23 with Trendelenburg, aggressive fluid treatment. Notice the blood pressure did drop. Her respiratory rate became less labored. Okay. Any questions on that one? Diff breather, 0632 hours. Engine crew gets the initial assessment and treatment. Patient's a COPD, CHF, or COPD patient. So what do we do? If a patient's COPD and they're having trouble breathing, what do we do? Put them on oxygen and most likely a nebulizer treatment, right? Yep. Lady is standing in tripod position along the edge of the bed or the dresser. Labored respirations, 87% pulse ox on HOMO2. They originally did the non-rebreather mask with CombiVent. SpO2 approves at 97%. This also was when we were first rolling out end tidal. So we was talking to a couple guys earlier how we had this battle of do we put on a regular oxygen or do we put end tidal on, right? So we get there, we put on the end tidal, and we notice that there's no waveform, no bronchospasm waveform, but she's in respiratory distress. All right, ding, ding, ding. There's something else that's got to be going on here. Okay, let's hold off on the nebulizer treatment. Let's focus on what's going on. We actually put her on CPAP. Noted that she had a fever, okay, and then also in discussions with her, she had some difficulty breathing, but she was actually denying difficulty breathing, but she was in clear respiratory distress. So do you ever have that where a patient is not matching, they're denying what actually is going on? So to me, it's telling me that she's not getting oxygen in the brain. She's not thinking clearly. She's in a fight or flight type situation. She's trying to stay alive. Okay. Short, choppy sentences, and somewhat denies those signs and symptoms, like I said. And then we also noticed that her arm was red and swollen. Her right arm was red and swollen. What can that tell you? Could be a DVT or something, though we normally think. What's that? What kind of infection?
If she had any sort of open wound or anything like that.
Right, so you,
Temperature comes into play right now.
right, so start looking for that. In this case, she had cellulitis, right? You guys ever see those patients with cellulitis? So cellulitis progressed into sepsis, and she was in respiratory distress because she was septic. So she had very poor perfusion, she had poor gas exchange, and everything else, okay? Again, we didn't get too focused on the COPD aspect. We can use this as a tool to guide ourselves down the right path along with our assessment, okay? There's some of your vitals. And again, this is a long time ago, so we didn't take temperature like we should have. Would have been another indication, right? Oh yeah, she got really bad and crashed also at the hospital. A can of Coke, just to put it in perspective, how many people just give like a 250 bolus to start with on most patients? Like that's general, would you, huh? That's pretty much general. Well, if you look at a can of Coke or pop or something like that, that's 250, 300 mLs. So that also puts things in perspective. You got like an end tidal of 14 on a sepsis patient. Is a can of Coke really going to help much? No, right? We might be less aggressive if we don't use this tool and just go by, say, blood pressure or whatever else. All right. Sudden onset chest pain, crushing chest pain. Here's your vital signs. See anything important? Nothing so far? All right, what about now? Pretty bad? Does not look good. There's a whole lot of bad stuff going on, right? Aside from reading the top, what type of MI do you think is going on or this patient's having?
Inferior, but check the right side.
Inferior lateral and check right side. Why do you check the right side? For right-sided MI, right? In this case, there's also a little trick that I've learned. Some people say it doesn't work, but I've seen it work every time. Have you guys ever looked at lead 3 elevation being larger than lead 2 for a right-sided MI? I think it works great. And if you think about where your patches, if you do a V4R, where your patches are lining up and what they're looking at, I think V4Rs are looking more at, are showing more of an extensive right-sided MI versus a less extensive, whereas the lead 3 larger than lead 2 is looking at a different angle and will actually show the right-sided MI a little bit sooner, in my opinion. So I've seen lead 3 larger than lead 2 before the V4R shows up, if that makes sense. So every one of my right-sided MIs that I've seen coming through reports and everything else have always had lead 3 larger than lead 2. So just something to think about. But with regards to patient treatment, how do you guys treat those right-sided MIs? This is something that's kind of controversial depending on where you go. Fluid bolus and no nitrates. And there's still people out there, including doctors, that will say, well, you can still give nitrates despite fluid. I don't agree with that. It doesn't sound like you guys are either, right? And this is rather indicative of that. So not only having a right-sided MI, let's see if we got our vitals here. This patient was, and again, several years ago, great case, but not necessarily good for the patient. Heart rate went from 93 to 114 with treatment progression. They were treated with aspirin, nitro, right? Blood pressure was fine, so that was part of the rationale to not, or to give nitro. Well, the blood pressure is fine, so I can justify giving nitro despite the fact that it's the right-sided MI, that's essentially, right? So there went the vital signs with treatment progression. You can see what happened there with the blood pressure. Respiratory rate increased, and blood pressure, or I'm sorry, end tidal was around 20 initially and dropped down to 11 to 15 with that course of treatment. Did we help the patient or hurt the patient? Hurt him. Now, if I'm looking just strictly at blood pressure with this patient, a right-sided MI, I might be kind of mistaken. But look at the end tidal. If I look at the end tidal and I see a 20 and a right-sided MI, what's that going to tell me?
You already have an issue.
You've got an issue. I don't want to make it worse. So in that case, I'm probably going to be really aggressive with my fluid boluses on that right-sided patient. Or it's going to make it much more of an emphasis, and it's going to further justify me not giving nitrates to this patient. Okay? So it's a different train of thought. Unfortunately, there's still a lot of people that go strictly by that blood pressure and go, well, we need to open up those coronary arteries, and we need to give nitro to help with that. But are we helping the patient or hurting the patient if we're decreasing perfusion even farther? Right? All right. So are there any questions so far about what we talked about? I know some of you guys were gone most of the time, which doesn't help. Providing this comes out, I have a screen recording of it. All right, and I'll get that to you somehow if it comes out. All right, but in closing points, so I really think that end tidal can help us. All right, helps us provide better patient care. It helps us assess our patients to have a better idea what's going on with our patient. I know that with me, it's helped me tremendously in my level of care. I've seen it with us. I've seen the resistance to it and the acceptance with it, and how it's changed how we treat our patients, how we approach our patients. I'll give you another example of a case real quickly. So we got called for a stroke, and the patient was unconscious. It was an older lady unconscious laying in a church office. Nobody saw her go down, but it was noticed that she had some right arm droop or drifting at times. She was not able to illustrate what her problem was. She was semi-conscious, had brief moments of lucidity where she would start talking about her problem, but otherwise out cold. So are you picturing stroke? It's possible stroke, right? And what are we treating? What are we teaching now about strokes? We obviously need to get them to either a place to get TPA or get them to a place to bust out the clot or take the clot, right? AHA is teaching not to give oxygen, right? Does it make sense not to give oxygen to this patient, do you think? She's unconscious, semi-conscious, like?
Doesn't make sense to me.
No, it doesn't make sense to me either, right? So we have to use that with a grain of salt. The crew had it driven in their mind that we're not supposed to be giving oxygen to stroke patients. Is there any guarantee this patient is not a stroke, or any guarantee that patient is a stroke patient, number one? No, we don't know for sure. I guess if the patient's up and talking to me and it's very clear cut, that's great. But in this case, she couldn't tell us something. They just saw a little bit of a drift. So our rule has always been, if you give the patient oxygen, then we want the end tidal measured. And I have to say that we have to do that with a grain of salt now, because in this case, the cannula wasn't put on and the end tidal wasn't measured. And so now we just lost our most valuable vital sign. And that patient went to the ER, and again, a lot of times the hospital's going by what we tell them, right? And we set the tone a lot of times. And if we set the tone by calling this a stroke alert, which it was, and she was activated as a stroke alert, and then she went to get her CAT scan, and nothing led them down the road of stroke other than this right arm thing once in a while. And then all of a sudden she had brief moments of consciousness and she'd complain about abdominal pain. All right. She had abdominal pain, and at some point, finally, well into her care with us and the hospital, they did a scan of her belly and saw that she had a AAA that was dissecting. Okay. So had we put on that end tidal and measured it, what do you think we would have seen? She's breathing normally. I would have expected to see a normal waveform. We'll start you there. Right. So something else was going on. If we would have read that, I can't guarantee it would have happened with every person, but hopefully somebody, every care provider, because we're all at different levels, right? But where I want us to be and where I'd like to see everybody be with regards to our profession and even in the ER is to see that and go, wait a minute, this doesn't make sense. Why does she have a low end tidal? Why would a stroke patient have a low end tidal? If they're breathing normally and adequately, why? It doesn't make sense. So let's start thinking outside of the box a little bit and go, wait a minute, this isn't a stroke alert. There's something else going on. Well, if she's got really shitty perfusion, is she getting oxygen to her brain? No. Mimicking the stroke. It was mimicking the stroke. And that lady, another person, sat in the ER, had delayed care, and ended up dying on the table during surgery. And at least an hour went by. Granted, she was an 80-year-old lady. She had a good life. But could she have been saved? It's very possible. It's very possible. All right, all because one thing wasn't done. And that's the part that bothers me, is because, like I said, I'm emphatic about this, and everybody's got to be excited about something. Some people like lights and sirens and shit, or whatever. This is what I like, but it makes a huge difference, right? So I know it's a tough class to sit through sometimes. It could be a little dry. Sorry. Hopefully you got something out of it. Hopefully it changes your mind a little bit as far as just as long as you don't tell someone to take it off. It does make a huge difference. Remember, you're going to walk out of here today, and some of you are going to go to use it, and you're going to go, what the hell did this guy say? Or you're going to try to think about it, and you're going to, this is a long process. You're not just going to get this overnight, okay? I had to teach myself, and I've kind of made it my goal that I want to reach out to different people and try to help them get past that curve. I've done a few things on my own that I think helped me. I need to revise this a little bit, but if you guys are interested, I'll be more than happy to share this with you. It's a little cheat sheet. And if you don't want it, then you can throw it out, whatever you want to do. And since we got a few extra seconds, I'll go through some of this with you. I need to revise a couple little things. So what I did years ago is I went through, I'm fortunate enough, my wife works at U of M Hospital, so I can access just about any research study or anything. So when I started going through this process, I came up with this chart to try to help myself or coach myself dissect through these types of patient situations. So, I'll turn the lights on here. Well. So your typical quadrant, these are quadrants I'll call them, your lower right quadrant is almost always going to be where you see the majority of your patients. Okay, so if you go down to that lower right quadrant, I break it down into respiratory emergencies, hypoperfusion states, and metabolic states. Okay, so if you walk up to your patient, you start assessing them, you got a low end tidal, and either increased respirations or relatively normal respirations, that's your quadrant. And those are the things to start thinking about. Okay, so based off the top, you see it says evaluate the waveform, then evaluate the end tidal levels, and then evaluate the trends. So you walk up to your patient, you evaluate the waveform. Is the waveform normal or is it abnormal? Right? Do we have a bronchospasm or do we not have a bronchospasm? Okay. Right there, respiratory emergencies. If we don't have a bronchospasm, we just knocked out most likely asthma, COPD in most cases. Okay. Unless they're in true respiratory failure and you've got a shitty waveform to begin with, then all bets are off. All right. So you can knock that out. All right. So what else is going on here? Well, we could have, depending on the patient's situation, we could have hyperperfusion states. We could have, if we have a low end tidal, right? So we can start thinking about those different things and knocking them off our list. Remember, the CHF is probably the thing that I'd like to change a little bit. I have in there pulmonary edema. CHF, remember, is going to be more of a normal end tidal versus low. Okay. But you can see there's a whole host of things to think about. Most of those we talked about today. If you have the asthmatic that has a worsening waveform, then you may start in that quadrant when they have a mild bronchospasm. But as time goes on, they're going to have an increasing carbon dioxide and potentially a slowing respiratory rate because they just can't get air out enough. So then you're going to move up to the upper left quadrant. All right. You go to the upper left quadrant, you'll see there that there's also asthma, COPD, and everything else, and it's severe and late in that case. Okay. So you may actually at times have a severe asthmatic that has a normal end tidal because they're moving from that hyperventilation state and they're moving to the hypoventilation state. All right, so you kind of cross over. All right, you can see that severe pulmonary edema and or CHF would be over there too because that's something I need to correct because typically if you have someone going to respiratory failure, you could have decreased respirations, right? But a typical CHFer, high respiratory, normal end tidal. I got to figure out how to illustrate that on there. But you can see there's all kinds of different things. Those are your two main quadrants. And maybe it'll just help you navigate through this a little bit more. Okay? I'll let you look at that for a second. Remember ventilation, perfusion, metabolism, all three of them come into play. You got to think about that with your patients. Okay? Any other questions? Feel free to ask me. I'll stay as long as you want if you have questions, or I know some of you guys missed pretty much all the presentation. So if you have any questions.
I can help you get that to him too.
Okay, cool. Thank you. All right.
Thank you.
Thank you, guys.
Thanks.
Thank you. Thank you.
There's also, there's a book out there that is pretty down and dirty and easy. This guy used to teach for Medtronic also, has since moved on. But he wrote a book that's a pretty simple down and dirty book that you can read through to help reinforce some of the stuff we talked about. I go a little bit more in depth, so I know it's overwhelming, but if you want to look through this before I take off, feel free, thumb through it. All right.